Your coffee or refill your plate.
Already, I've got 9 o'clock. $3 in tolls, 85 miles an hour. It's 9 a.m. Good morning, everyone, and welcome to the Valentine's Day edition of GETAC Council meeting. Since we love and respect each other on our journey, it is appropriate to tell your neighbor in the audience or on the council, Happy Valentine's Day. Happy Valentine's Day. And send a text to that significant other one so you stay out of trouble. Great, thank you. And wiped about. The vision of GETAC is a unified, comprehensive, and effective EMS and trauma system for a healthy, safe Texas. The mission of GETAC is to promote, develop, and maintain a comprehensive EMS trauma system that will meet the needs of all patients and that will raise the standards for community health care by implementing innovative techniques and systems for the delivery of emergency care for the entire population. And having read the vision and mission statement, I'll entertain a motion for approval of the minutes. I have a motion and a second. All in favor? Aye. Any opposed? Minutes passed. At this time, I'd like to let you know we have some new faces on the council. Replacing John Smith is Lieutenant James Williams. He was unable to make this meeting. And we have Linda Dickerson as our general public member. She was reappointed. In the EMS medical director position, we have Dr. Jeff Beeson to my right. Would you like to say anything, either you or Linda? Nope, I'm seeing. No? Okay.
It is a great honor to get an opportunity to serve 6 more years. I thank all the people who, when the governor's office called, that y'all said nice things, and I will definitely be paying you off in Valentine's candy later. But thank you so much. But it is a true honor to serve, and I pinch myself that I get to be with y'all another 6 years. Thank you very, very much.
Thank you, Linda. We also have reappointed Judge Mike DeLoach to my left here. Okay. And in the urban trauma facility position, we have Dr. Brian Eastridge over here to my right. Would you like to say anything, Dr. Eastridge?
No, sir.
Okay, thank you. At this time, I would like Dr. Ronnie Stewart to come on down. Sorry we're interrupting your coffee. Dr. Stewart is no longer on council. He's our former vice chair, and you're one of the founding members of the GETAC Council, correct?
I think so.
Okay. Well, believe it or not, I have a certificate here I'd like to read to you and then present to you. It's from the governor. It says, to all to whom these presents shall come, greetings, know ye that this official recognition is presented to Ronald M. Stewart, M.D., in recognition of and appreciation for his years of meritorious service to the state of Texas as a member of the Governor's EMS and Trauma Advisory Council, 2000 to 2014. It's signed by Rick Perry, the governor. So I'd like to present this to you and thank you on behalf of the entire council for your service. It's been an honor and a pleasure serving with you on this council.
You're here.
Dr. Stewart is going to speak and tell me how he went 14 years on the council without any gray hair.
Well, I have a lot of gray hairs. So, I would say it's been a great honor and a privilege to serve with each of you and to work with all of y'all. I'm not dead yet, so I'm going to continue to work inside the Texas EMS and trauma system. I guess the one thing that I would say is whenever I first started with GETAC, and I guess it actually dates back to EHAC and TTAC, I view in some ways that I was given a great gift by people who came before me, people who came before those councils, and so I would emphasize that we're all given a great gift by the people who've come before us. And I think the things that we've done best in building the Texas trauma system, which I think is a great honor to have been a part of, and is kind of a shining light for a lot of emergency healthcare systems from a system point of view, is we learn to work together, to listen to each other. I certainly have learned a tremendous amount from you and from the people in the audience. And I think moving forward, it's really important to continue that tradition of listening to each other and keeping the patient or the citizen of Texas centered with respect to everything that we do. I'm going to sort of address the audience too, in that I'm given a lot of credit for things that I didn't do. And you don't need me to do the things that you need to do. To do the things you need to do, you need to keep the patient front and center with respect to what you know to be the right thing to do, and to listen to each other, be respectful of each other, and build a much better Texas trauma and EMS system. So, you're given a gift. I'm looking at Dr. Eastridge. I'm just teasing. We're all each given a great gift, and it's been an honor to work with you, and I look forward to what's to come. So thank you very much.
Thank you, Dr. Stewart. Thank you, Dr. Stewart. And of course, now the vice chair position is open, so I will be begging another council member to serve in that position alongside me. Our next item on the agenda is Director Guerrero is going to go ahead and give the Assistant Commissioner report because Commissioner Perkins is unable to attend this morning.
And I'm just going to combine, if you don't mind, Vince, I'll just move from Kathy's report right into mine, so hopefully it will be relatively brief. First thing I wanted to talk to you about is Sunset. You're all aware that DSHS is going through Sunset Review. We have been actively working with Sunset Commission and providing them information on how our agency works. They're in the process of developing their report. It has not been released yet, but we're expecting that this will come out sometime in the spring. The timeline for public hearings, we're anticipating those will occur sometime in the summer. Again, these things have not been solidified, so it's really to be determined yet. I think the complexity of some of the things that we do kind of put them behind on what they thought their timeline would be. But as we get more from them and we know more, we will pass that on to you. Last legislative session, you're all aware that SB 8 was passed, and we've been in the process of implementing the legislative changes that were mandated for us to do. You guys looked at the rule packet last November at your last meeting that was going forward in order to implement those changes. That will be posted on the Texas Register, should go up today for a 30-day comment period. So if you're interested in looking at that, you can go to the current posting of Texas Register, and that revision will be there. From November, there's really nothing that was of substantive changes. There were some grammatical changes that were made. For example, we had spelled out emergency medical services, and that was shortened to the acronym EMS. So those types of things were the changes, but nothing really substantive. We are also working on the report that was due to the legislature. It was actually due January 1st, according to the statute. We did get a little reprieve and got that pushed back because that was a very aggressive timeline for us to try to turn that around. This was a report that was combined between DSHS, the Texas Medical Board, and HHSC, the Medicaid shop. So what we did, we came together, the three agencies came together, and we produced a single report in a collaborative arrangement, and that is what is going through the final review and editing process within the agency before it goes on to the legislature. It includes DSHS's recommendations as was prescribed in the law. It also will have attached as an addendum the complete document that the EMS committee produced and brought to GETAC. So that will go forward in its entirety. Also, with regards to, really plays into SB 8, is there's a CMS moratorium on new EMS providers that has been extended until the end of August, and that was extended from, I believe, February 1 through August 31st. So no new providers will get a Medicare provider number until after August 31st. Any questions on these items so far? Nope. Okay. Also, I'd like to let you know that we have hired some additional EMS specialists in Houston. We have 3 that have come on since your last meeting. Sasha Shepard, Blake McLines, and Chuck Rowe are our new EMS staff in the Houston area. And this is really difficult for me to say because that's coming from Fern, and I'm used to Fern being in San Antonio, so I had a hard time getting Houston out related to Fern. Also in the Office of EMS and Trauma Systems, we have a new State Trauma Systems Director, and this was actually one of the recommendations in the 2010 ACS Systems Assessment that we bring that position back. In 2010, I didn't know if we would ever be able to bring that position back. We were able to do it this year. Colin Crocker. Colin, are you here? Oh, okay. Colin Crocker, who was the RAC coordinator, was promoted into that position. Colin has a bachelor's and master's degree from University of Oregon. His master's is in public administration, and he holds a certificate in nonprofit management. The RACs are 501c3 nonprofit organizations, so he brings some really unique credentials and abilities to the table to assist in with the RACs and in our trauma system development. We're really excited to have him. He's sort of since he's not here, I'll say it, he's sort of a data geek, and we're kind of excited about that, okay? Especially with our new registry product that's coming online that John will talk to you about. I'm really excited about having him on board. The funding report you have in your packet, and it gives you, we're providing for you now a spreadsheet, not really a spreadsheet, but a little track record on the numbers of trauma facilities. That's on your front page. We're doing it by quarter. We hope this is helpful for you. When you see in active pursuit facilities, there's about 30 of them, I believe, reflected on that report that are in active pursuit. The reason that number is so high is that we've had a lot of change of ownerships of hospitals across the state, a lot of buyouts. Anytime there's a buyout, change of ownership, the designation does not transfer. It's just like the hospital license. It does not transfer. The new owner must get a new license. Therefore, the new owner must also get a new designation. So they go in active pursuit. The advantage of being in active pursuit is that they can participate in the uncompensated trauma care funding, which we are in the process of calculating now. That's really the only advantage to inactive pursuit. It's also a 2-year window of which they have to then become designated. They already have a mature program. It's really not an issue for them. Are there any questions on the funding report? One thing you might notice is that on the local project grants this year, we increased it by $300,000. We went from $1.3 million to $1.6 million in local project grants. That's probably a one-time shot. It'll probably go back next year, but we were able to do it this year. We are pursuing, and some of you have been actively involved with our agreement or our working with American College of Surgeons to try to, again, meet one of the 13 priority recommendations that the college gave us back in 2010, and that was to complete regional assessments of all 22 regions. We are working with the college, and we are working with schools of public health to try to make this happen. We had meetings this week with stakeholders and the RACs to help develop the process that we're going to go through to do this. It is a huge undertaking, but I think we have support certainly of our assistant commissioner and our department and the stakeholders. Everybody wants to see that we can get it done. We want to do all 22. We don't want to do a smattering or a sampling. The position is pretty much we do all 22 or we don't do any of them. So right now we're still in talks with the ACS and developing that process and in talks with the stakeholders, so you'll be hearing more about that. Any questions at this point? Then that concludes my report.
I did have one question on the trauma designation in the funding report. At the top it says GETAC November 2013 report. So are these numbers as of November or as of today?
That would be as of today? Okay, sorry.
That's okay, thanks.
Yeah. My bad, typo.
Any questions for Director Guerrero? Seeing none, we will move on to Jana Zumbrun, the Assistant Commissioner of the Division of Disease Control and Prevention, and I don't see her here, so somebody else must be.
Yeah, John Villanacci.
Yes, sir.
Thanks, Chief. Give you a brief update on where we're currently at with the trauma registry. As you may remember, last November, last meeting, my staff had discussed with you some of our future plans for the registry. Well, future has been moving forward, and we're in it now, so we've been moving forward. First and foremost, we're really excited at this point where we are on target for implementing the NTDB and NEMSIS standards for Texas in 2014. As you may or may not remember, the NEMSIS and the NTDB standards were built into the registry, and they are in the registry, but we've delayed the implementation of it only because we were giving stakeholders and users time to upgrade their systems so they'd be able to submit to those levels. So 2014 is the year we're going to be starting to collect those data. We have several ways that data come into the registry. You know, some hospitals submit with their vendors software packages or their own software. Others do web data entry. So I'll try to break this out a little bit in terms of what we've been doing for each of those users. For those users that currently do hospital web data entry, right now the new 2014 NTDB questions are already available for them. So they can actually start submitting data to those levels. This past December, we held 4 training sessions for those users to discuss how they would be answering those data elements. And if needed, my staff can provide additional training to users. In addition to the NTDB questions, the registry also includes question packets specific to Texas. We kind of call these the Texas custom questions. And those are going to be available to the web data users in May. And prior to that implementation, we'll be providing some training on those as well. For the hospitals that submit data through electronically or through their own software, they will be able to start reporting both the 2014 NTDB and the Texas custom questions beginning July of this year. In the meantime, we're going to be working with their vendors to test the processing of their files. One of the larger vendors has already contacted us to schedule testing of their file processing. And we'll be continuing to work with both the users and the vendors to implement and deploy these data elements. For EMS submissions, we're currently in the process of being certified by NEMSIS for reporting NEMSIS version 3 data. I guess that's the latest version of NEMSIS. And during this process, we'll be working with both the EMS users and the vendors to test the NEMSIS file processing. Implementation for 2014 EMS data submission is scheduled for the summer. So they'll be able to start submitting this summer. Overall, on a bigger issue, you know, the software package or the software we use is called Maven. We're currently upgrading the trauma registry to the latest Maven software release. This is Maven version 5. And this is going to provide us a lot of additional functionality, one of which is improved data validation. We've been updating the training slides for using Maven 5 to accommodate the changes, and have put these already on the system registry dashboard page, and they'll be available upon deployment. And our targeted update for completion of this actually is February 21, so just a couple of weeks. As far as future funding, we have submitted another application to TxDOT, and the state, of course, does the match. So this is for 2015 funding, so we'll be notifying you as we find out about receiving those fundings for continuing improvements to the registry. Any questions? Okay, thank you.
Thank you. Next, we have Dave Gruber, Assistant Commissioner, Division for Regional and Local Health Services.
Okay.
Okay.
All right.
I think he's running a little bit behind.
Okay, well, we will move on down to the agenda, and when he gets here, somebody let me know, and we'll get him back in. Next, we have the Preparedness Coordinating Council, Eric Epley, who's Vice Chair of the Preparedness Coordinating Council. And you are welcome to give your Disaster and Emergency Preparedness Committee report at the same time.
So I apologize, I was out of state for the PCC meeting, but they did re-elect me while I was not there to the vice chair role. Yeah. So there's something to report. With respect to the Disaster and Emergency Preparedness Committee that met on Wednesday morning at 9, we had a briefing on the Texas Disaster Medical System's mass fatality efforts. They continue to build out what they're calling TMORT, the DMORT equivalent, the Texas version of that, and we're excited to see that moving forward with medical examiners from around the state, the justices of the peace, and integration. Mass fatality, we know, is going to be a major issue if we ever have a crisis. We had a briefing on the Emergency Medical Task Force, and that effort has several things that are exciting to report. One is that we finalized the air medical MOA, and we fully integrated, finally, all the air medical contracts into a single point of contact in the EMTF program. So now we have ambuses, we have ambulances, we have field hospital, we have nurse strike teams, medical incident support team members, ambulance staging managers, and the final piece of the puzzle really is this air medical component, being able to dispatch aircraft on a state mission rapidly. I want to thank Rick Bays and Jeff Hokeem, especially from the Response and Recovery Division from DSHS, who've helped us immeasurably at that, and the air medical provider directors. We have a medical incident support team class March 27 and 28. We're doing that in Arlington in conjunction with NICTRAC. We have an ambulance staging manager course next week, actually, in Galveston on the 18th and 19th. And those are both full or nearly so. We spoke about a new name change. You may hear the Regional Public Health and Medical Operations Centers instead of just Regional Medical Operations Centers. By adding public health into the name, we feel like that's going to increase popularity and deployment much faster. We also discussed extensively our next steps. So we have a lot of these initiatives that we see, fingers on the hand, EMTF, TDMS, mass fatality, lots of things that we've accomplished, but as a group we think it's time to look at the next steps. And some of the things we had conversations about were to redouble efforts on pan flu. You know, it seems like in the early 2000s, 3, 4, 5, 6, we kind of got, I think if I'd heard pan flu again, I was going to vomit. And then we, for the last 5 years, though, if you really think about it, besides 09 and H1N1, we were dusting off some concepts and thoughts that we hadn't really thought about in a long time. And I think now this may be a good time for us to, new group of people, right? We've had attrition and lots of new folks, and so we're gonna focus a little on that. We want to talk some with the power grid, so Chief Kidd's going to arrange for the Public Utility Commission emergency preparedness person to brief on that, because Texas, we're blessed in Texas. If you don't know, there's 3 power grids in the nation: the Eastern U.S. grid, the Western U.S. grid, and the Texas grid. So I thought that was the way it should be. The final thing I thought was interesting was someone brought up the fact that with respect to disaster preparedness, we need to focus on the ACA, and that what we're seeing now is a sicker population at home, which will create a larger burden during evacuation, or if we have a tornado in a community. You know, 5 years ago, 10 years ago, certainly, we didn't have as many people on ventilators, we didn't have as many people on other home health care, and so we're going to look at the impact of that, and maybe some bright resident or something from UNT would love to do a poster or something on the impact of ACA and disaster preparedness. So I'll take any questions. And then one last point of order, and I don't know if this is the right time or not, but I'll just do it because I'm here. The May GETAC meetings are going to be here in Austin, but the Texas Division of Emergency Management's Emergency Preparedness Conference is in San Antonio, same week, same dates. Many people are going to be in sort of basically both locations, and there's something, graduation or rodeo or something here. I have a lot of my folks on committee saying they can't find hotel rooms in Austin for that period of time as well. So if we could consider some appropriate but some sneaky, I don't know, some way, it would be helpful. I think Chief Kidd would be amenable to finding space down there at the TDM conference to be able to move, if we can move GTEC there like we do with the EMS conference when we go to Fort Worth or wherever it changes. So I'll take any questions.
Any questions for Eric? Do you have any business that council needs to vote on or discuss at this meeting? How about next meeting?
I'll have it in by Monday.
Okay, thank you.
Close of business, beginning of business.
1700, sir.
Next, we'll hear from Air Medical Committee. Shirley.
Thank you. Air Medical Committee met Wednesday afternoon. A couple of things that we did that I'd like to report on, and of course the first one is the completion of the MOU for the air medical responders. It was a long time coming. A lot of people put a lot of work into it, and I can't tell you how happy I am to have that project finished. We did get the word that the draft was complete, and so it is ready to go. So it's really nice to have that done. Eric Epley played a huge part, I guess you know, in making that happen. So, Eric, thank you again. The second thing I'd like to report on is the rule language, the draft rule language that we presented to the council back at the November meeting. We did some draft rule language a year, 2 years ago, and then the model state guidelines came out. We did a gap analysis between our draft language and the model state guidelines. We found some areas that we didn't cover or we didn't feel like we had covered fully, so we went back and added to our draft. That's been completed. We've been over it several times in the Air Medical Committee. It was approved at our meeting on Wednesday. So we need to send that forward to the council for approval, and would like to be able to send that on to DSHS. If you want, I'll go. We did this, I believe, in November. We had the additions, the revisions. And I can go over the areas that we addressed in those additions. The definitions and the acronyms we did not have in our rules. We added those. There's a clause on personal and professional liability insurance requirements. There's an item in there on subscriptions. Must provide the name of the most medically appropriate provider. And that basically was the change on that one. Demonstration of financial resources, patient privacy considerations, detailed access of service clause. We added the frequency of review of standards at least every 7 years. Circumstances in which one medical team member could not transport with the patient. A medical equipment list including the vent and waveform entitled CO2. We added the 95th percentile weights and heights, policy to address bariatric patients, which seems to be more and more common, guidelines for transporting multiple patients, and then integration into incident command. So those are the areas that we added some clauses on. And that's pretty much it.
Okay. Anything for council to vote on at this meeting?
Absolutely. We would like to have that addition to the language passed so we can send it on to dishes.
At this meeting or the next meeting?
If we could do it this time, it would be okay with me. That was when at our November meeting we talked about that, and I did report that we would have that for hopefully for approval this time.
Okay. I think we've handled these more recently when they're done with the committee reports. So go ahead and make the motion, and then we'll discuss it and then ask for public comment.
Okay. So you want the motion now?
Yes.
So then I would like to make a motion that we pass the addition to the air medical draft rule language that was approved at our air medical committee meeting that we've discussed before.
It's not on your agenda.
It's not on the agenda.
Can't make a motion.
We haven't seen the language yet.
Okay, we'll do it next time.
Okay, we'll do it next time. Next we have, I'm sorry, any other questions for Shirley? Okay. Next we have the Cardiac Care Committee, Dr. Smalling.
Thank you, Chief. For those of you who didn't know, Chief Riley ran the Houston Marathon in January. What was your time, Chief?
Almost 6 hours.
No.
Bottom 100 finishers, but I did it.
Congratulations.
Thank you. And now Dr. Smalling can tell us about the half marathon that I believe you finished.
2 hours and 20 minutes.
There we go. All right.
25 out of 81 in the old fat guy age category. I think it's probably my last one. Any rate, we had a good meeting yesterday. Lonnie Den kicked it off with a brief report on the Action Registry, which is the American Heart Association voluntary registry on STEMI care. She reported that 132 hospital STEMI receiving centers out of a potential 150 participate in the registry. 900 hospitals are participating nationwide. And that's going to be important for a little bit later in the report. Dr. Wozniak is our ad hoc representative to the DISH's Cardiovascular and Stroke Council, so he's able to attend those meetings. We're trying to develop an interaction with that because it's felt that some of what we do overlaps a fair amount with what they will be doing, and so that's an ongoing thing. He did meet on Saturday with them. He felt that the GETAC Cardiac Care Committee could benefit from access to the DISH's infrastructure, such as the database and epidemiology units, and that conversation continued later on in the meeting. Catherine Bissell then reported on recent upgrades in the content of our GETAC DISH's STEMI Care website, which is housed on the CETRAC server. Dr. Cooley, Christine Uhas, and David Wamper are going to assist her in further enhancements to the site. If you haven't had the opportunity, you can go on the Cardiac Care Committee portion of the DISH's website and click on other information or something like that. I don't remember. Jane, do you know the link? Resource. Thank you, Catherine. Resource documents. I think we're going to rename that so it's a little more specific. But there are articles from the literature based on EMS results, emergency medicine and cardiology results, general guidelines, how-tos for various geographic regions in terms of developing STEMI systems and so forth. So it's already a pretty good website, and that's going to continue to be developed. Next, Dr. Wozniak, who is our data meister, if you will, led a lengthy discussion regarding the proposed RAC STEMI Care Survey. There were numerous suggestions proposed by the members of the committee as well as the public, and we're going to make a recommendation or a request for action on that. It'll be our first one with potential money involved. During the public comment period, Katie Wignicki, I think is the way she pronounces it, from DISH's, in the chronic disease manager of DISH's, described a $500,000 allocation from rider number 97 for the support of stroke and STEMI data registries. And then she described what the monies will be used for. In particular, they will be extracting data from the Action Registry, the HA Action Registry, the NCDR ACS Registry, which is American College of Cardiology, the Stroke Registry, and some others. There was considerable discussion about this, and particular issues arose regarding the possibility of adding pre-hospital information to the STEMI patients. The pre-hospital via NIMSIS is not easily linked to the hospital outcomes, and Eric Epley suggested a solution that they have evoked in San Antonio, but this is something that we need to discuss further, and there was some discussion about establishing STEMI as a reportable disease, which might facilitate this. There was some discussion since pool drownings are a reportable disease, and things other than infectious diseases now have some reporting ability. If it was made a reportable disease, then that would, as I understand it, short circuit some of the HIPAA issues and so forth. So that's just informational. I think we're going to have to talk about it. But if the the council could consider that, I think that would be helpful. We do have a motion. There are about $3,000 per rack that have been earmarked from this rider to go to the local racks. And we would like to propose or recommend the GETAC Council require dishes to require that all state racks complete the cardiac care gap analysis survey as a prerequisite for recipient of those funds. And the idea would be if further monies are available down the road, then we would have an idea what various geographic areas might need to help them help themselves. And whether it's 12-lead ECG machines, staff, whatever, we can't basically can't think about potential funding for those unless we have the data back. So that's the motion.
Okay, this would probably be the same issue we just had with Air Medical, and that it would have to be to go on next council agenda in May.
That was two different issues, wasn't it?
Was it?
You just had two different issues, right?
Sounded like you just had two different issues. The second one was the funding, and the first one, now I'm forgetting. But it sounded like you had two.
Well, no, though the other one was just
The reportable disease. That was
reportable disease. That was just for discussion. I mean, is it possible? And folks are going to look into whether that might be feasible.
But
the main motion is providing. If they want the money, they need to send in their report. That's basically the bottom line.
But if you want us to take action next meeting, it has to be on the agenda for the next meeting.
Okay.
So it sounds like you have two issues for the next agenda. One is to make STEMI a reportable disease, and the other is the funding that I didn't follow.
I'm not sure we want to go there, Bobby.
Okay.
I think it was brought up. I think we need to talk about it, vet it. I don't know what the possibilities are, but it probably might be one or two meetings down the road if everybody agrees that's something that would solve some problems. Okay.
I think that goes along with the discussion we had as council about a topic that's of importance in figuring out which committee should be working on that. So is that something we want to discuss now as a council, or just ask cardiac care to explore it further? Or
I mean, to get efficiency, I'd like to go ahead and put it on the next council agenda.
Okay.
If we don't talk about it, it's okay. The problem is if it's not on the agenda, we can't talk about it, we can't take action. So I would actually like to put that issue on our agenda for the next council meeting. Then if we decide not to do anything, that's fine.
So the next council meeting, next GETAC meeting set is right in the middle of UT graduation. Which our youngest daughter's graduating, so it's going to be, we have to figure out something creative about that.
You'll send someone.
Okay.
I'm going to be competing in the X Factor games that week, so I'm tied up as well.
Concludes my report.
Any questions for Dr. Smalling?
I don't have one specifically for Dr. Smalley, but when would the money be eligible to be handed down to the racks absent his motion to have a prerequisite of the gap analysis?
What they're looking at doing is putting it onto rack contracts in our shop. So it would take contract amendments because this year's contracts are already in effect. Some of them are already completed. So it's a contractual amendment, but the racks have to agree to it. If they're going to, it's not something that we would say you have to do. So the racks have to agree to it. That program has to get that buy-in from the racks and let us know who's going to do it, and before we amend those contracts.
There was some talk about the money being tied to deliverables, and they hadn't figured out what the deliverables might be. at this point, as I understand it, but I'm not part of that. So.
Well, absolutely. The money would always be tied to deliverable, and that would be a contractual amendment to an existing contract. If it were for this year, for next year, it could be for upcoming contracts. But again, this would be something that I don't know that all RACs would participate in. They may not have the ability to do what they want, and that's really for that program to get with the RACs and figure out what can they do. We've given the information of the RACs that that currently collect some shape, form, or fashion of stroke data, and to so that they have a starting point as to which RACs to talk with. And I think they've already had some of those conversations.
Good. Anything else?
Okay, so to clarify, for the May meeting, there'll be 2 items on the agenda. 1, consideration of making STEMI a reportable disease, and 2, the funding component doing the gap analysis, correct?
Does that go to the council, the second one? Or is that
It could bypass
through the
it.
rack and the
It could bypass
dish?
It could bypass. Dishes
I'm just
could
asking
do it,
Jane.
yeah.
I'm sorry.
Dishes could just do it,
That just goes between the rack and dish, right? The second topic. About the
On the gap
contracts.
analysis?
Yes, and the contracts with the racks.
Yes. I mean, the council can ask the RACs if they can do it now. The RACs may or may not be in a position where they could get that done, but it could be made as part of their contract for the future. Yeah.
So you would want I think what Dr. Smalling is asking for is for the council to recommend to dishes that they do that. And so, or is that just none of our business at all?
Oh, you can make that recommendation. That would
Okay.
be fine.
Does it require our recommendation?
But in May, yeah, it'll be in May.
yeah.
Does it require it? I don't think it requires it.
No, they can do it anyway.
Yeah, they should do it.
But you're certainly welcome to.
Okay.
Thank you.
Thank you. Okay, next we have Education Committee. Jody?
Good morning, everyone. Education Committee met in Hurst on January 10th as well as yesterday. We had 4 items on the agenda. Council members, if you would look in your packet, there'll be a letter dated January 10th to the chair and council members. You all remember the last couple of meetings that we've met. We've had looking at some issues that the Texas Higher Education Coordinating Board is moving to make all associate degree programs 60 hours and all baccalaureate programs 120 hours. As we begin to look at this, it's one of those things that popped up from Senate Bill 497. Started to really take a hard look at it, and a lot of the colleges, universities started saying, you know, that I'm not sure if that's something that we want to do. Many colleges have had to go ahead and trim their programs back to 60 hours, which is a loss of core. So the committee's met with input from a lot of people there. I appreciate the input from Austin Community College, Hill, Tarrant, several others, actually too many to mention. But one of the things that we noticed is that there was a possibility that the coordinating board had built in and developed a process for the exemption to the 60-hour rule, and that when we looked at several of our colleagues in respiratory therapy and sonography and others had written a letter to the coordinating board with support from their trade association. GETAC has considered that to many. I'm going to read the letter for those of you all that don't have it, so bear with me for just a second. Governor's EMS and Trauma Advisory Council Education Committee has examined Senate Bill 497, which amends Section 6105151 of the Education Code that will reduce the number of college semester hours of an associate degree to 60 hours effective fall 2015. Paramedic programs in Texas and in 47 other states are accredited by the Commission on Accreditation of Allied Health Education Programs, called CAHAP, on recommendation from the Committee on Accreditation of Educational Programs for Emergency Medical Service Professions, called COAMS. CAHAP reports that there are 35 accredited programs in Texas, with 28 of them offering associate degrees. 26 of these programs currently exceed the proposed 60-hour requirement. The standards and guidelines from COAMPS do not specify a minimum or maximum number of credit hours for accredited programs. However, Standard C3 states the curriculum must ensure that the achievement of program goals and learning domains. Instruction must be appropriate sequence of classroom, laboratory, clinical, field internship activities. In Texas, EMS Rule 15732 states the minimum paramedic curriculum shall include all content required by the current National Paramedic Education Standards and competencies in the National Education Standards. The rule took effect January 1st, 2013 and ties a national accreditation to Texas programs. Senate Bill 497 allows for an exception of a 60-hour requirement for, in parentheses, and I quote, compelling academic reasons. According to the Texas Higher Education Coordinating Board, a compelling academic reason is a justification for an associate program consisting of more than 60 semester credit hours. Acceptable justification of programmatic requirements, statutory requirements, and requirements for licensing and certification of graduates. The Education Committee makes the following justification in support of the allowed exception. And we looked at transferability, Affordable Care Act, independent practitioner, and industry growth. Under transferability, the 60-hour requirement places significant difficulty on the transferability of an associate degree to a baccalaureate degree. The Texas Higher Education Coordinating Board requires 15 hours of core content in the associate degree and 42 hours of core content in the bachelor's. This difference of 27 hours of core curriculum between the two degrees adds a fifth year more to complete the bachelor's. Under Affordable Care Act, which is our statutory, EMS providers are experts in remote care. As we support the growth of our profession, we must realize that there will be significant need for associate degree paramedics to expand in the community-based preventative medicine practice to reduce the cost of health care and augment better delivery of health care. At a time when EMS is expected to expand its role in community and critical care, the reduction of semester hours appears to be very counterintuitive. Independent practitioner and licensing. Even though paramedics are not licensed as independent practitioners, they function as an autonomous role under the supervision of a distant medical director through delegated practice. Paramedics must be able to use critical thinking skills, problem-solving, decision-making in the field, and the education paramedic personnel must include a solid foundation which will allow them to deliver competent patient care. Education is the key factor in providing proficient care for our patients and enhancing the ability to the physicians to improve patient outcomes. Under industry growth, the desire to standardize associate degrees is appreciated. However, the 60-hour mandate limits the need for growth in the profession. The difference between certified prepared and associate degree prepared paramedics should be in the area of leadership, supervision, management, critical care, community health, research, and beyond. Excellence. EMS education is establishing consistency in cognitive, psychomotor, and affective domains. The Texas Department of State Health Services, GETAC, National Association of EMS Educators, Department of Transportation, and many other organizations are working through the education standards and accreditation to assure competent clinicians. Requiring programs to reduce their paramedic curriculum to 60 hours would not be in the best interest of the citizens and the community we serve. Based upon these recommendations, the Education Committee respectfully requests GETAC to support the exemption to allow paramedic associate degree programs to standardize from 68 to 70 credit hours. The Education Committee believes these justifications to be the compelling academic reasons. It was not the intent of our group to change what anyone was doing, but the right to actually have them continue doing what they were doing. If a program can get it done in 60 or 65, great. If you need 68 or 70, 72, great. We want what we're asking for GETAC and the motion on this item. Do we want to do it now or we want to do them all at the end?
Do you have more report?
Yes.
Okay, go ahead and continue with the Education Committee report and we'll come back to this.
Okay. There was some discussion, and we just wanted to make that very, very clear that our goal was to allow programs to continue to provide the education that they needed. We looked at item 2, which was recommendations of ethics and integrity standards. Dudley and I talked about that. We're going to try to work together on that as we foresee some jurisprudence exams and some things coming up in the future. We want to make sure that we're giving due diligence and due attention as we look at other healthcare professions that require ethics and integrity exams, or at least CE. Item 3 is one that we had already handled, and we took that one off of our committee. Item 4 was preparing EMS medical directors. This group had worked on that for several years, and actually members of the Education Committee, we've actually put on probably 3 or 4, no, actually 5 medical director courses throughout the state. A couple of you have been asking for them, and we haven't been able to get all the physicians that normally do them together at one time. We've had several of them who've been involved in getting their new EMS boards and just trying to get them together in one spot. We like doing them. We think it's a great course. We've invited other people besides the medical directors, new EMS chiefs and captains and lieutenants. And we think it's really not just for medical directors, but it's for anyone who is involved in the day-to-day administration, either at the provider level or the education level. Our state EMS director, Mr. Smeeder, presented the guide for preparing medical directors, which is pretty much the same course that we had done, but this one is available online. The state is hoping to provide this for a year for all medical directors to be able to take this course online. It will be one of several. Still be able to take it in classroom style, but also to take this one online. Joe, did you want to speak to this in any fashion?
I don't think at this time, no.
Okay.
You're summarizing fine.
Okay. Would be available online. There would be a cost to the state if we're able to do it, but they're willing to absorb that cost for the first year. After that time, people would have to pay. So probably looking, I believe, from September to September of this coming year to be able to allow them to do that, and certainly the Education Committee supports that. The course would include EMS overview, systems, medical oversight, personnel and education, responsibilities, quality improvement, medical director's role, state and regional issues, and then there would be a final exam to go along with this. And the group voted, and we certainly support that. We will meet on April 4th in a work group here in Austin at a location yet to be determined from 9 to 3. That's all.
Any questions for Jody? Seeing none, we'll go back to the action items you have for us. We'll start with the letter on the 60-hour limitation first. We need a motion.
Motion based upon the recommendation, the Education Committee respectfully requests GETAC to support the exemption to allow paramedic associate degree programs to standardize their credit hours.
Second.
Okay. Is there any discussion?
Just the Medical Director Committee discussed this letter and endorsed it. I believe it was a unanimous vote.
Any other council comments? At this time, I'll open it up to any public comment. Looking for public comment on the motion. Seeing none, we'll close public comment. And so, just so I'm clear, this is to support the recommendations as stated in the letter, and we're advising dishes to tell that to the coordinating board, or this is just a letter from GETAC that goes with those who are going to support it, just for clarification?
Yes, this would be a letter from GETAC to any of the colleges, and anyone that asked, is GETAC supporting this? And the answer would be yes. A copy of this will probably end up at the Texas Higher Education Coordinating Board.
It's a letter that can come from the chair.
Okay. That's what I was clarifying. Any other discussion? Go ahead and vote on the motion. All in favor?
Aye.
Any opposed? Motion passes. Thank you. And then, Jody, did you have a second item that we need to take action on? Is that item 5 on our agenda, or is that that's about the online medical directors?
No, that was just
okay.
Advising.
Okay. All right, thank you. Next, we have the EMS committee report. Dudley Waite.
I'm sorry.
Hmm?
Your question?
No.
No.
I think they're playing Candy Crush over there or something. Because I know I would be.
And I've used that before at City Council. I'm working on an issue. The EMS committee met Wednesday morning after disaster, and we went through several things on our agenda. We had a presentation from the Texas Medical Association on their program, Hard Hats for Little Heads. This is their 20th anniversary, and they're trying to get a lot of publicity for that and get a lot of helmets distributed. They have a grant program. Basically, it's a buy one, get one free type of offer for helmets. So they're $7.30 or $7.70 a piece, something like that. And if you buy 50, you get 50 for free. So it's basically for about $350, $380. You get 100 bicycle helmets to distribute in the community to kids 16 and under. And so they're trying to get that. And I believe there's still some flyers out on the table. And they do have a website. It's called Hard Hats for Little Heads. And they are wanting to get as much participation as they can this year. An EMS week would be a great time for that. We asked DSHS where the rule changes that we've been working on the last couple of GETAC meetings were, and they're going out for publication in the Texas Register on February 15th, or maybe next week. I don't think they're going to go out tomorrow. But anyway, I guess they go out in the one today, or they'll be out next week. Recommendations, we also asked, our next agenda item was asking the status of the report to the legislature, and I think y'all got an update on that already this morning from DSHS staff. And one of the things that we were told is that paper that we worked on will very likely be attached to that overall three-agency report in its entirety as an addendum, so that the work that the stakeholders put into that will be able to be seen by the legislature, which I think is critical, and I think it speaks highly of the information that was in that report as it came straight from the folks that are doing the business every day. So I thought that was really good. We got an update from EMS for children, and then we got an update on the timeline for all the revisions to Chapter 157. DSHS is still working on that, and Joe said he's going in there and making a bunch of changes just to get everybody all mad and spun up, and then we'll come. No, he didn't say that, but anyway, that's probably what will happen. Anyway, we've got a report on the trauma registry work group, and Brian Petrilla, who's the EMS committee representative to that, had some data that had been pulled from that was rather interesting, showing the number of EMS agencies and how many ambulance agencies are actually submitting data. It's right around 37% on the data they had as of the end of January. For last year, about 37% of the EMS agencies had sent data in. So we got a lot of work there to get the 100% compliance by the EMS agencies. So more to come on that. And then got a report on the work group between us and Air Medical, and I think medical directors are involved in that, about patient care issues when there's an air medical provider and a ground provider on scene. That is kind of, the questions keep leading to more questions, so DSHS supplied them answers to the questions that they had regarding issues when on providers when the on ground providers when the air medical provider has an issue, and how DSHS views the responsibilities of the ground providers, and if that ground provider is a lower certification level than the air medical provider. And then that's morphed into some issues we're having around our state on some of the border areas with other states regarding if these air medical providers come from out of state, then how does that work, and things like that. So the questions and the answers to the questions they had have led to more questions, and so they're continuing to refine those. I think once they get to a point where the questions have all been answered, I think we'll probably get a good report out of that, and maybe some good information to share with all the stakeholders. Got a great report from Victor Wells with the Emergency Medical Task Force with some of the activities they're doing and some of the opportunities for EMS agencies to continue to get involved. And then we started talking about possible agenda items for next meeting, and we have a few that we would like to ask you all the ability to look at. First one is 2 or 3 years ago, some folks in the EMS community raised some concerns about the local project grants. and some of the dollar some of the dollar values that are listed in some of the grant guidance for items, and that there's other items and higher technology that is leading to better patient care and more safe environment for field responders. And the local project grants have not always been able to assist in some of those purchases in an appropriate way to make them feasible for some of the smaller agencies around the state and some of the rural and frontier folks that are doing the bake sales and those type of things. And not really much happened on it back then, and so it came up again within the last month or two from some agencies and actually some vendors who were working with some RACs who were interested in using local projects for a RAC-wide initiative on provider safety. And so I talked to Mr. Schmieder, and we brought it up with the EMS committee, and the EMS committee would like to look at that local project grant process. It's too late to do anything this year, but for 2015, and maybe help provide some guidance in the way that could be more beneficial or offer some different alternatives for DSHS to contemplate in setting that up, so that we truly are maybe getting more bang for the buck, so to speak, either in changing the way that the grants are given out, or helping to provide updates to those supply lists that they look at and the dollar amounts that are there, based upon things that are coming or things that are out there already in our industry that are being proven to either provide better patient care or to provide responder safety and less workplace injuries. And I'll give you a couple of examples that have just because I know some of you are like, what is he talking about? The grant guidance says that the maximum they'll give towards the purchase of a new or used ambulance is $35,000 based upon a $70,000 purchase price of a new ambulance. Anybody that's tried to buy a new ambulance, you can't buy. It's hard to buy a supervisor vehicle for $70,000, let alone an ambulance. So those type of things. The other one that has caused a lot of concern, it was a concern from my agency about 8 or 9 years ago, and other agencies since, are things like track stair chairs that help assist getting downstairs, and powered stretchers that have been shown to help reduce back injuries in providers. And the dollar amounts that DSHS currently in the grant guidance have listed in there are a maximum of $2,000 to the purchase of a stretcher and a maximum of $300 to the purchase of a stair chair. And a tracked stair chair is around $3,000, and a powered stretcher is around $12,000 to $13,000. So it's just to help try to get that up to date and to move forward and to provide some recommendations in the talking of it in our committee, as well as various folks who brought it forward. I think there's a lot of things we could do there to make that process a little bit, I guess, more user-friendly. I don't want to say more user-friendly, but help keep up and help providers get some things that right now that grant's not really being that helpful towards. The other thing is we wanted to look at, or it's not really going to be an agenda item. I think we'll get updates from Mr. Schmieder on that, but it came up about some issues with reciprocity when folks who live near the border of Texas and other states, maybe their initial education course is closer in another state. They take that course, they get their national registry. Currently in policy, there's not an easy way for them to be nationally registered and come to Texas and go ahead and apply and get their Texas certification because they took the course, say, in Oklahoma. So they need to get their Oklahoma certification and pay that money and then come to Texas and apply for reciprocity. And so I think it's, I don't want to say it's an easy policy change, but I know that Joe is looking at making that policy change, so we'll be keeping him updated on that. And then we want to kind of follow on. We're watching what the medical directors are talking about psychiatric patients and some of the risks and issues associated with transport of those patients when they don't have medical needs. And the EMS committee would like to continue to follow that, but also have some of our own discussion as a committee as well on those exact same needs. So the medical director's conversation on that kind of spurred some desire on our committee's part to also have some discussions on that.
Any questions for Dudley?
Well, you talked about the issue with control of the scene and transfer care of patients and all of that. I mean, the medical directors are very interested in that since it's our patient to begin with. So if you can send me kind of what that topic is on your agenda, I'm going to put it on the medical director's agenda.
Okay.
And then we can see when it can come to council and see if
Okay.
other
That's-
committees need to look at it.
That's actually the work group's already there. You talking about the air medical ground provider thing? Or the psych patient?
We've talked about this before, the who's in charge when there's multiple services and transfer of care and all of that. And I don't know that we've ever really completed those thought processes.
Yeah, and that's actually where some of that discussion about it was an operational thing, but now we're getting into that. I think some of those questions are being spurred. So, Shirley, if you'd share who's on your work group from your side, and I'll share who our folks are, and then we'll let you guys figure out how y'all want to handle that. Because I thought y'all were originally involved in that, and I don't know. It's dragged on a little bit because we kind of lost track of it with the change in EMS director roles there. So,
Going back to the local projects grants, sounds like the issue is a dollar doesn't buy a dollar anymore. Is that really the case? The finances need to be updated?
I think part of that is the finances need to be updated, but there's also been some discussions about exactly how to do that. And so I think the stakeholders would like to make some suggestions to DSHS or to GETAC and hopefully to DSHS, because there's multitude of ways those things could be handled, and a lot of interest in it. It could right now they try to limit the dollars they're going to give, and there's questions about should the grant application stand on their own merits, or should it be capped at a certain amount, and those type of things. Do you give more preference to rural and frontier areas over urban areas? RACs get involved in this and do RAC-wide projects and things like that, which are kind of an entirely unique thing. And so a lot of folks have just had concerns over the years, and we talked about it 2 or 3 years ago, and we just never did anything with it. And so we'd like to start discussing it now to see if there's other suggestions we can provide to DSHS to make sure that we're getting the most out of that program that we can.
So it was talked about 2 years ago at GTEC level or at the committee level?
At a committee level. Came up at the committee level.
Okay.
Dudley, one quick question. I was looking back, and the EMS committee had asked the council in a previous meeting to develop a work group to evaluate the availability of paramedics in certain areas of Texas. And I think, yeah, EMS, medical directors, and I forget, let me look, education. Has there been any progress on that at all, or is that something you're going to be looking like in the future? I know your plate's pretty full right now.
No, ma'am. We didn't reach out to those committees to put that together. Okay. The medical directors did have an agenda item and a document on the website for their agenda on a report that was done by the Public Health Office at Texas Tech, I believe. And very insightful report looking at EMS in West Texas and the availability of it, and the availability of paramedics, and the availability of air medical services and things like that. Very insightful report. And my committee, we found it during the medical directors committee yesterday, and that was the fourth thing I wanted to ask you, if we could also discuss that. I know medical directors, I don't think y'all got to it yesterday, but I know they're going to look at it, and that may be the stepping off point for that work group. That report may have done a lot of the legwork that some RACs were trying to do with surveying the folks in their RACs. So it may help cut the work of that.
Thank you very much.
Okay. Any other questions from council? So I think, correct me if I'm wrong, we heard 5 different issues. We heard the who's in charge at a scene when there's aeromedical evacuation being considered. Yep. And so then I would think that the council then would decide which committees need to work on that, or is there already a work group?
That work group's already established.
Okay.
It sounds like if Dr. Greenberg's amenable and the council is amenable, that we'll reach out and make sure we have medical direction involvement in that. I think it's at a point where if we didn't have it before, we definitely need it now.
Well, they've talked to me a couple of times.
Okay.
And I've gone to the meetings, but not consistently.
Okay.
And we can see if
I'll get Justin to send you the answers, and then you can, if it's okay at the council, Dr. Greenberg can continue to represent or decide who's going to represent from him. We'll make sure they're included in that work. Okay.
And then the second issue was the local project grants, and that would be on the EMS committee agenda for the next time you meet. Is there any other committees that might want to meet and discuss that? Put that on their agenda.
I know I was approached by some RACs. They're not really a committee, the RAC chairs group, but they want to be a part of it, so I think they'll probably attend the committee and participate in the discussion.
Okay. Well, I was thinking EMS have a dog in that fight, or no? Local project grants are pretty much hardware, right, primarily?
There's education, and that a lot of times is done.
Okay.
Again, that's one of the things the RACs are interested in, because the RACs use local projects for a lot of RAC-wide initiatives, whether that's education or equipment or
Okay.
Local injury prevention projects, whatever.
So Jody, do you want that on your next committee meeting? Okay. So we got EMS and education working on that one. Then we have the transportation of psychiatric patients.
And what we want to do is follow up on the work of the medical directors on that.
Okay. And can council think of any other committees that need to consider that as a topic? Nope, hearing none. Then there's the reciprocity issue of crossing the state lines to get your certification in Texas. Is that something that's going to be handled by DISHES, or do we need to?
I think Joe is working on that, and I think we decided if we put it on the agenda, it would be asking him for an update on where that is, because he's doing a lot of work with our surrounding state EMS directors.
Okay. And then the last issue is the availability of paramedics, and I think that's a work group that's already been established.
Yeah, y'all have already allowed that. We just didn't get it going this round.
Okay. Anything for council's agenda for next time?
No.
Okay. One last call for questions. Seeing none, thank you very much.
You bet. Y'all have a good day.
Can I make one interjection real
Sure.
fast? I know Joe wasn't here when we traded blows over accreditation. One of the biggest things that was sold as accreditation was the fact that the person's certification would make them mobile. And I think that it's disingenuous to make that argument for accreditation and not fast track this repair to the rules. I mean, how can we say that we want accredited programs to send our people to other states, and yet we have people, especially those of us that operate on the borders of Texas, we have people coming to Texas who have taken a national registry class, and if it was good enough to accredit it in the state of Texas, this should be a no-brainer and a really fast action.
Okay. I think Joe's going to fight you for the microphone, Dudley.
No, well, I ain't going to fight him.
So let me just say that in concept, we're all on the same page. What we need to do is look at the rules and the legislation. That's where the work needs to be done, not just in Texas, but all of our surrounding states. So concept, we're moving forward, but we got to make it all happen legally.
Okay.
Chief, I was accosted by one of my committee members who happens to be the one that takes notes, and I left off one other agenda item we would like to work on, and she reminded me because it's a really big deal for her and in her current municipality. But with all respect, you didn't put a space between mine and yours, so that's why I didn't see it. But anyway, that's neither here nor there. Chief Kaye from Dallas Fire brought up to us in the legislation that was passed, there were some requirements in there that for new organizations that want to start after the moratorium's over, they have to get a letter of approval from either the county or the city. And she asked if we could have it on our agenda to start discussing some of the pieces of that apply to EMS, because that has to answer three things. Those letters have to answer three things, and a lot of municipalities and counties are starting to scratch their head about that. The three things it has to answer is there a need? Will it impact the current providers? And will adding another one fix the problems that they think they're having? So she asked that be put on the agenda. The committee agreed unanimously we needed to address that because it's coming up in all of our communities now as we're getting closer to the end of the moratorium, and TML and TAC starting to talk about it.
Okay. Any other committees that we might assign that to?
I think that it's definitely a medical direction issue as well, because ultimately it's a perception of the care that's being provided, and that kind of trickles down onto the physician. So I would think that people need some learned input in this process. They need to know what they expect in their community before they can answer what they need.
Okay, we'll add that to medical directors.
And so give me a bullet point on how I can put it. I'm building my agenda as we speak.
Well, I see. You're not going to wait to that 45-day mark, are
No.
you? It is requirements on for letters of attestation from a city or county due to House Bill 3556 and Senate Bill 8.
Yeah,
I'll send it to you in email.
What he said.
I'll send it to you in email.
Yeah, he'll send it to you. Okay. All right. Thank you,
That's
Doug.
it.
All right.
Is that it? Okay, that's it.
Okay.
I'm good to go now.
No more accosting. Next, we have Injury Prevention Committee, Shelley Stevens Stidham.
Good morning. The Injury Prevention Committee met on, had a workday meeting on January the 17th in Dallas, and then we met Wednesday afternoon. We also had data from the Trauma Registry Solutions Work Group presented. We're very excited about the fact that that data is moving along, and it looks like we're going to have some really good data for Texas pretty soon. We also heard about the TTAF Just Drive campaign. I believe that's been implemented in 5 or 6 high schools in Texas already. They have done pre-assessment data and will be doing follow-up data, and so we're excited to hear more about that. I believe as part of that campaign, they're also going to do a community-wide pledge not to text and drive, and it's not just texting and driving, but also looking at distracted driving. And so that's probably going to be a day sometime in May that even adults can take that pledge, and we'll let you know more about that when we have that date available. We also had a presentation from this year's the Trauma Registry Group on Texas injury indicators for 2011 data. We'll make that. John Helston did a presentation on that, and we'll make his presentation available on the dishes or on the GETAC website after I get back. At our workday meeting, what we just worked on was developing some recommendations and suggestions for hospital-based injury prevention programs. These are not going to be regulations or anything like that. It's going to be suggestions for components for a good hospital-based injury program. We've had represented from TTAF, TTCF, RACS, and level 1 through 4 trauma centers. So we're trying to make it applicable to all trauma centers, not just those in level 1 in urban areas. And so we've tentatively decided on 5 component areas. One is the need for data. One is engaging partners. Third is providing continuing education and training for the injury prevention coordinator, trauma coordinator in the hospital. The fourth one is selecting and implementing evidence-based strategies, and the fifth one is how to do evaluation. And so we're in the process of, we've developed some subcommittees. We're recruiting participation on for each of those 5 work groups. If you know of people, we've trying to send those out to TTCF, TTAF, RACS, but if you know of people who would like to be on those work groups, we're going to try and plan work group meetings either by conference call or face-to-face between now and May 2nd, which is our next workday meeting. We're going to plan on trying to develop a packet that will include information about each of those 5 component areas with examples showing examples for level 4s as well as up to level 1. We hope to bring this to the GETAC Council by the November meeting. The other thing that we're working on is we've drafted a workforce development position paper on workforce development for the injury and violence prevention field in Texas. Hope to pass that by the committee by May and bring it to the council by the August meeting for approval as well. And then finally, we've had 3 resignations of committee members, unforeseen resignations. 2 people took new jobs, had hoped to stay a part of the committee, but just in the end couldn't do that. And then one was a new committee appointment who had to resign as a result of health reasons. And so we're looking to fill those slots. I'd probably need guidance on how to do that. Do we recruit? Do we wait until September when committee openings open up again, or?
I'll get with you and Director Guerrero, and then
Okay.
Dr. Greenberg and Mike here. We'll figure out how we do
Okay.
that. I think they stay historically. I think they've stayed vacant until October.
Okay.
But that's yeah, it's an awful lot of spots, and
Right.
We don't want to reduce the effectiveness of your committee. So we'll figure that out.
Okay. And then finally, I think I mentioned our next workday meeting is May the 2nd in Corpus Christi.
Any questions for Shelley? Okay. Thank you very much. Medical directors, Dr. Greenberg.
All right, we met yesterday with a quorum. In fact, we only had one absentee, and she's in Antarctica. We thought that was a reasonable distance away to miss the meeting. We went per our agenda. Under action items that we had, we endorsed the Education Committee's letter, which has already passed through this council. We have approved a position statement and sample clinical guidelines about peace officer requested blood draws, and request that that be on the next council agenda. And I'll give you these in writing. Okay. We endorse the NHTSA, NAMSP, ASEP EMS Medical Director course, which I don't know if you've talked about already or not. Sorry, I was late earlier. So we endorse that as well. For future agenda items, I gave you the first one. We are also going to have some talking points and sample protocols regarding use of spinal motion restriction and long backboards. At this meeting, we discussed a position statement, and really through the discussion, it turns out we really need more to give paramedics and EMS and hospitals more of the talking points rather than just a position statement. So the position statement would say why we feel that way, but it still doesn't give everybody the tools they need to explain why. And since it's really a culture change, that's something we're going to work on for the next meeting. And we'd actually ask that be on the council agenda as well. And then we're going to continue to talk about transport of patients with behavioral disorders. That we, again, worked on a position statement for that. It became very complex very quickly, and we'll probably have 3 separate items on that. But we request that to be on future agenda item as well. We also did discuss the ASEP report card, although very briefly. I know that's on our agenda as well. There is a video that is available if we can. I don't know if we can do audio video through here, but no audio? It's not good to watch yeah, unless people, does everybody read lips? No, that won't work very well, so, all right. Yeah, if we can get, it's a 2-minute video, so we can try it whenever we get to that on the agenda item. Then I'll give you the link for the video. And that concludes my report.
Any questions for Dr. Greenberg? Thank you. Pediatric Committee, Dr. Macias.
Thank you. We met yesterday and welcomed 2 new members, Diana Krause from Austin and Justin Hensley from Corpus, expanding our geographic scope for pediatrics, and had only 1 absent member. We had a discussion over our minimizing CT radiation position paper, really discussing what we intend to do for an implementation strategy to help institutions and to really help drive the concept that CT radiation is a significant issue in PEDS pre-hospital and transfer issues as well as ED-based settings, so that we will have an implementation straw man to bring to the committee. We'd like to have this as an agenda item for our next session. Part of that is related to rules that apparently don't go up for revision until 2017. These are radiation TDSHS, radiation exposure rules, and so we'll have some recommendations for what we'd like to see that would be consistent with what other states have done, namely Pennsylvania as a shining example for that. Let's see. We had a presentation for hard hats for little heads as well. And we had our EMS state partnership update. A significant part of that update was a discussion of the National Pediatric Readiness Project. For those of you that are unfamiliar with the Pediatric Readiness Project, that is a national project sponsored by federal EMSC, and has had a tremendous rate of response. Here in Texas, we had a 60.5% response. That was 305 out of 504 hospitals. And our average Texas score was 70 for our low-volume institutions, which was less than 1,800 patients. Our score was an 82 for our high-volume, greater than 10,000 patients. Score was an 84. Where that puts us with the rest of the nation is pretty much on par with everyone else. With the other big sites. What's most interesting about that, and I guess it really does seem somewhat intuitive, is that as the annual pediatric ED volume increases at any sites across the country, so does that readiness score. So really, which comes first, a sort of cyclical nature to that. But it did highlight a number of issues related to where our current gaps are within the state, and really drives back this issue that the Institute of Medicine has described in Growing Pains in their ED series, and that was this gap in regionalization, especially for some of the more critical pediatric issues and how that links to outcomes. So I'll come back to this issue, but in particular it is an agenda item that we're going to ask about to talk about a voluntary recognition program. I'll come back to that in a second. Our next discussion was related to pediatric transfer guidelines. We now have a task force that is headed by Sally Snow that has met and really created quite a bit of work looking at models like Washington State's pediatric consultation transfer guidelines. And the purpose of the guidelines really isn't to supplant current working relationships between agencies, hospitals, and transfer sites, but really to create a framework that helps define transport teams, burn guidelines, methods, checklists for inter-facility transfers. We'd like to bring this package to the committee, so if we could put that on the agenda for our next session, to have the pediatric guideline concept approved with the materials that we'll hopefully have vetted. There's intent to vet this pretty much through most of the other committees as well, so we'll be reaching out to all the other committees in our next session. Let's see, future agenda items. One of the areas that we had early talked about was looking at quality improvement strategies, and what this National Pediatric Readiness Project helped us to recognize is that with even a fundamental core set of metrics, we can most easily identify where some of the gaps in quality and outcomes exist. We'd like to be able to expand that, taking an inventory, working with the other groups to look at what some of the system PI metrics are that are specific to pediatrics, linking that to what EMSC has, and then looking at the more expanded scorecard that EMSC has. Linking all of that ultimately to a voluntary pediatric facility recognition program that we'd like to see supported through EMSC, but really empowered by this organization. So this is the agenda item that we'd ask to put on the next committee meeting for really a two-phased or two-pronged approach. The first is to evaluate the opportunities and describe a very rudimentary program so that we can move then to other organizations with endorsement and fine-tune what that might look like, both with professional societies, with academic societies, and with advocacy organizations. So I think that covers all our agenda items. Any questions?
Any council questions for Dr. Macias? You mentioned agenda items several times. Did you intend for any of those to be on the council's agenda? Or
on the council's agenda, yes.
On the council's agenda. So
that was
the
transfer guidelines.
Transfer guidelines.
Radiations, including 2017 rule revisions, and volunteer pediatric facility recognition program. So those three agenda items.
Okay. Is it transfer, transport, what exactly?
It's transfer, inter-facility transfer guidelines.
Okay. Who should be transferred, or for the transportation between facilities?
It's all-encompassing. Okay. It's definitions, who's at risk, what are issues related to.
Transfer.
ultimately anything that affects the outcome of a child who's transferred between facilities.
Do you know which other committees have talked about these 3 items?
I do not know the answer to that. I do know that the interfacility transfer guideline discussion will have hopefully agenda time at almost all the other committees that are pertinent. So probably not stroke, for example, but
right. So do we need to assign those to committees to make sure they're on the agendas?
I think so.
Okay. So,
so the only agenda item that goes to the other committees is the interfacility transport.
Okay. Any other questions? Okay. Thank you.
Thank you.
Stroke committee, did they meet?
No.
They did. Okay. And then trauma systems, Jory Klein.
Good morning, Mr. Chair, committee
Morning.
members, council members. So the trauma system did meet yesterday afternoon. We did have a quorum. We only had 2 people that were not present. So the topic of the agenda, obviously following the posted agenda, there were some critical issues that happened. I guess obviously the ACS Trauma System Survey was probably one of the big topics of the whole GETAC meeting process. So we'll summarize that. So the first thing is they had the Trauma Registry Work Group meeting. That happened on Wednesday. Good things are happening with that. And I just want to thank Tammy and the members of that work group, Brian from EMS, because we're really beginning to come together and do good things instead of argue. So we're moving forward. The next thing is we do have a Trauma Medical Directors Work Group. Brian Eastridge, who's new to GETAC, congratulations, Brian, is the chair of that work group. And again, he's looking at multiple issues, and probably the biggest thing that continues to be out there is the geriatric trauma patient and the geriatric guidelines. Now, TQIP did publish standardized guidelines for all the trauma centers through the American College of Surgeons, and so that's one of the starting points to begin to look at that. We also have a work group for mid-level non-physician providers. The goal of that particular work group is to look at collecting job descriptions, to standardize elements of the job description, to look at an orientation manual, to look at how to access the ATLS courses, as well as a career track for those individuals. The Trauma Registry Group, mostly of their activity was rolled into the Trauma Registry Work Group, but they will be doing the same thing, job descriptions, career ladders, standardized processes for the Trauma Registry role in the hospital. One of the big discussions, again, came about the data and how to use the data. We have a trauma system PI plan that was supposed to be started in January of 2014 that has come through this committee 2 years ago, and it was signed off, so it is and the guidelines of implementation. So there's still a lot of questions about the data and how to do that, and so that's one of the issues that we really spent some time with. There is a proposal that's out there. We're going to regroup and look at that, and so what we're going to do is ask all the committee members to look at that and take it back to the RAC chairs and then to comment on that and bring feedback back to the May committee before we move forward on anything else. The ACS survey process, for everybody that was in the room, the recommendation was that Colin has created a list of questions off of the BIS format that is created by the American College of Surgeons. He's going to send that to the Trauma Systems Committee, to the EMS Committee, and to all of the RAC chairs, and what he's asking for is feedback within 30 days. So to address that, the Trauma Systems Committee will be looking, and I've already talked to Jane about this, an opportunity to have a meeting before the May meeting so that everybody that's part of that can actually come together and have comments and discussions, so it will be a unified recommendation list, not individuals sending things in from the Trauma Systems Committee. It will be a unified voice from the Trauma Systems Committee to Jane regarding the ACS survey. Any questions that I can answer for the group?
Jory, who's working on the mid-level work group?
It's Kelly Stowell. She is the mid-level provider at Scott & White. Dr. Gandhi from the Trauma Systems Committee is the physician representative on that, but it's open for anybody to participate. And then the one other item that I almost forgot to bring up is we did have Matt Davis come from Scott & White, and he presented an overview of the TQIP process. For those of you who are not familiar with that, that's the American College of Surgeons Trauma Quality Improvement Process. So what happens is that hospitals send data to the National Trauma Data Bank. And then they pull your data if you agree to participate in it. They pull data out of that, your data, and then they do further analysis. And so what they do is risk adjusted, and they look at mortality, complications, and defining best practices. And so there are about 14 trauma centers in Texas that participate in that. And so one of the ideas is to see if there's an opportunity to create a Texas TQIP. Now, there are about 8 states that have done that. Michigan is probably the leader in that. Georgia did a presentation at the last TQIP conference. And so it really begins to look at how we're doing within our state. When you compare, it's almost like the hospital. So if you look at TQIP, it compares my hospital to Allen's Hospital and other people who have participated in it. This would compare our state to other states, or we can ask for a different type of review from that. So again, it would be some type of funding, but Matt is looking at options and opportunities. And so again, if there's anybody that would like more information on that or would like to participate in that, I would suggest that you call Matt Davis, and I can give you his phone number if you're interested.
Any other questions for Jory? Do you have any items for Council's May agenda?
Not at this time, sir.
Okay. All right. Thank you very much.
Thank you.
Next, we move to the GETAC Liaison Summary Reports, and we have TTAF Dinah Welsh.
Good morning, everyone. Happy Valentine's Day. I just have a few things that I want to update you all. It's been mentioned, the sunset process, and that's something that TTAF will be following very closely to try and expand upon sort of the part of the picture that DSHS has shared in their self-evaluation of the trauma system. We are going to be working with Sunset to expand upon that, to share sort of the full story of what all you all do. So we will be updating you all throughout that process. The legislature has also announced their interim studies, and we will be following a number of those. The driver responsibility program is being studied once again, and so we've already had some conversations with the chair of that committee, and we will be having some follow-up conversations with him in person, hopefully in El Paso. That's Representative Joe Pickett. So we will be updating you all on that. We have planned a Trauma Day awareness program, have been looking to do that in May, and we've had some challenges with hotel space, so we're looking at possibly doing that in August. We'll let y'all know, confirm that as soon as possible. And then also, because of the May madness, we are delaying our fundraiser as well, so we'll be doing that in August, and hope y'all will participate in that. We'll let y'all know about that. Shelley did a very good job of outlining our Just Drive campaign. It is a distracted driving campaign that we have done in some areas throughout Texas. We will be rolling that out statewide. We have a website currently that you can access through the TTAF website. Has a lot of valuable information, we think, on that, and looking to partner with a number of RACs and other organizations around the state to get that information out. And the last thing that I wanted to mention is we are we are working towards a stroke cardiac conference. It'll be a statewide conference, September 26th. We've done stroke symposiums in the past that have been more about becoming a stroke support facility and the steps. This is going to be sort of at a higher level with, we have a number of doctors that have already agreed to speak at that conference. It's going to be at the Hyatt Lost Pines, September 26th, so put that on your calendar, and we'd love to have you all out there. Happy to answer any questions.
Do you have a flyer for that symposium?
Not yet. It's we just signed all the contracts, and as an organization, we are thrilled to be able to talk about something that we're going to do 7 months out. That's sort of a first for us. So we're, but we should have the flyers out here pretty soon. Thank you.
Will you send them to us?
Yeah, we'll make sure that at May we will definitely have those flyers, and then the newsletter, there will be attachments to that. All of you all should be getting our newsletter. Some of the newer members we will constantly update our list. The other piece that I will share with many in the room is that we are changing our email distribution list vendor Yay. We've had a number of problems with that. So if you're not receiving the newsletter right now, there's going to be another send that goes out on Monday, and then we'll be updating that constantly. So we'll let y'all know.
Any other questions? And again, thank you and TTAF for all this technical equipment here and letting those that can't come to Austin participate in the meetings.
Well, thank you. And Jason Meredith does a wonderful job. He's the man behind the curtain. It's been a little bit more challenging, and I think we've seen firsthand. I know that there was a lot of discussion about GETAC and having meetings going on at the same time and overlapping. Because of that pop-off room, not having microphones, not having the space, pretty much everything that's been going on in this room has been recorded. So for the first time, there are several committees that were not recorded. So we apologize for that, but it really was impossible. So, but just another thing, I think, as we all have considered, the various iterations of how you do GETAC and overlapping committees and everything, it is not something that we are ready to take on of having two rooms that we're recording. So,
right. We will try to keep these instances rare.
I know.
Okay, thank you.
Thank y'all very much.
Dave Gruber, the Assistant Commissioner for the Division for Regional and Local Health Services, has arrived, so we're going to bump you, Sam, just for a second and let this report be given.
Thank you, and my
Thank
apologies
you.
for
That's
being
okay.
late. But now that I know this is being recorded, any questions? I'd like to address 2 or 3 items, but also at the end, I guess I'm looking for a little bit of feedback as to what you want to hear from me to make sure that I provide you the appropriate information, but also so that we can take back to the office what we need to do to do things better. So if you could keep that in mind while I'm talking, I'd appreciate it. As far as Sunset goes and our division, we've had very little interaction with our division at Regional and Local Health Services and Preparedness. I think we mentioned before our preparedness group did sit down with Sunset. We've gotten very little feedback from that. And as far as our regions, we've had 2 visits. One was to our San Antonio region, the other was to our Houston region. Sunset will be going down to the Valley, but won't be meeting directly with our group. It will be meeting with a group of others in the Valley. So our interaction with Sunset has been pleasant, quite frankly, but has also been very limited. We've got 2 major initiatives through our office. One, both peripherally relate to the trauma system. One has to do with initiation of a statewide syndromic surveillance strategy and information exchange strategy. Particularly with the public health departments, the creation of what I'm calling a public health information exchange. The significance of that is that hospitals are required to link to a public health department for meaningful use. They've gotten waivers up to this point, but my understanding is from now on they will be required. There is no waiver coming. So we're working at making sure that there is that capability throughout the state, but also more importantly, making sure that we do link all of our public health entities to be able to share information. It's at the beginning stages. We're forming a governance board. We're looking at both the policy aspect and the technology aspect and ensuring that we do not supersede any already existing activities. Just as a side, there is a software analysis tool called Essence that many of the health departments use for analysis. We expect that to be continued to use. So whatever technology solution we're looking at, it's more of a backbone to a connectivity, not to analysis of data. So that's to be continued. As far as another major initiative we have, particularly with our health departments and what I'm calling the health system, we're looking at an overarching strategy for the health system. And to clarify that a little bit, to put things in perspective, we've created, and you won't see this written down anywhere except on slides that we present, a 5-tier system. The 1 tier is the overarching health, public health, mental health, anything that you can think of regarding to health and health-related pharmaceuticals. We call that a tier 1 level. A tier 2 level is the particular components of that overarching enterprise, the public health system, the healthcare delivery system, mental health system. And then Tier 3 would be different organizations within those particular categories, and then works down. We're working at the Tier 2 level, the public health system level. And the positive of that is that the department, along with our local health department partners, are working together as a group to come out with an overarching strategy for the public health system, not for individual entities, but for the public health system as a whole. And quite frankly, it's been an exceptionally great experience to see this, to see everybody working together to this. We'll be creating a vision and a mission, recognizing this is a vision and a mission for this enterprise, public health, not a vision and a mission for individual organizations. So where we are right now is we asked our local health department partners and we asked our own regions to provide a list of services that they provide, the current state of services. And we came up with about 100 or so services that are being provided in the field, some related to public health, some cross over a little bit to healthcare delivery. There was no attempt to say whether or not these were valid services. All it was a snapshot of what we're doing right now. We did an affinity mapping exercise, and we came up with approximately 7 categories of services that are being provided by the public health enterprise. Our goal right now, because what we did, even though we included local health department input to that, we did that actual exercise from our regional and our regional medical directors conducted that exercise. Our goal, based on conversations with local health departments yesterday in their meeting and with the 969 committee, is to now do this with the local health departments, so that in essence what we get is a true current state of public health services being given across the state of Texas, whether it's a state entity or whether it's a local health department entity. Next step after that would be future state. What does this enterprise believe where we should be going? Great English here. But where should we be going with this, so that, again, this is a common picture, a common belief in where we should be going health-wise. One of the reasons I'm bringing this up is, as I mentioned, we're working at a Tier 2 public health level. I would see advantages to that happening at other in healthcare delivery and mental health, because the whole goal would be an integrated health system that ensures that the connection between the different partners is there, and that we all are aiming for the same thing, which I think is quality, affordable, great health for Texans everywhere. So it's a major initiative, and even though it's a major initiative, we're looking at this being a less than a year initiative to get to what we see the outcome, which is identification of the health system, the public health system, where we should be going with it, and putting those steps in place to making sure that we're doing it the best way possible. Before I go any further, any questions on that? We're also creating a preparedness strategy, and we're creating that in-house to begin with as a straw man document that will be then sent out to our partners, the RACs, to make sure that we have a comprehensive understanding of the public health preparedness system in Texas and the healthcare delivery emergency preparedness system in Texas. This is important as we, without going into cliches, we have the artificial geographic and regional boundaries, but the key thing is ensuring that we can support each other when necessary, but still support what's necessary within our own regions. So we'll have more about that. And then getting to how I led into this, my purview includes the public health system, but it also includes the emergency preparedness component of what we do at the health department. So I need to get feedback from everybody on what we should be doing better, what we're doing right, and how to move forward so that we continually make sure that we're doing the right things. Doesn't have to be now, because I know I'm surprising you with that question, but either through standard chains of linkages or directly to me, everything that you say will be taken to heart. Thank you.
Any questions? Okay, thank you. The EMS for Children State Partnership Update, Sam Vance.
Good morning. Dr. Macias already spoke to you about a couple things that we're working on with the Pediatric Committee. So I just wanted to give you a brief update on the statewide EMS assessment that's part of the larger national EMS assessment that's being conducted right now. Our cohort closed on January the 8th. Our official response rate, as you can see from the map up here, was a 71%. Which, while is not the largest percentage response in the country, our total number of 326 agencies that responded is about the third highest in the nation right now. Unofficially, we had a handful of departments that wanted to participate in the survey that were not chosen by the computer in the random sampling. So we will be able to add their data in after we receive the state and national data, and that will bring our unofficial number up to 72%. We should be receiving that state and national data, I'm hoping, in March, as the last cohort closes at the end of February here, and would anticipate being able to have that data ready to present to you in May. If we could, we would like to present that to the council in May and have about 15 minutes to do that on the agenda. Lastly, I would just, we will also have the, be getting the 2010 survey data to compare the results from now to 2010. So we would hopefully like to see an improvement, or at least no change. And lastly, I would just like to thank all the departments that participated in the assessment. Would also like to thank the RAC chairs and directors for their help in contacting the agencies, as well as DSHS, and to you, Chief Riley, for your help with it.
You're welcome. Any questions for Sam? Okay.
All righty.
Thank you. Mm-hmm. Okay, we'll now move to the action items. Items 1 and 3 have to do with the GETAC strategic planning process. We're going to move those to the end. So we'll go to we've already done item 2. We'll go to item 4, which is review and consider the American College of Emergency Physicians 2014 National Report Card on the State of Emergency Care and the Results for Texas.
Is this yours? Yep.
Okay, Dr. Greenberg.
So in your packet is the Texas report card from the American College of Emergency Physicians. Every 6 years, I believe it is, the American College of Emergency Physicians puts out a report card for the environment of emergency care in the United States, broken down by states. It's a fairly complicated process. Overall, the nation didn't do well. Texas didn't do particularly well. So it is very easy to misinterpret the results and thinking that we're being told by our own organization that we're doing a bad job of providing care. The way I relate it is driving on I-35 doesn't make you a bad driver just because it's a bad, difficult road and it's hard to navigate. And that's the same kind of thing that the report card looks at. It looks at the environment that we work in, not the care that we provide. It's actually explained very well in this video, if we can get it to work, much better than I can do it, by Dr. Diana Fite. This is a video put together by the Texas College of Emergency Physicians. It's a 4-minute video. The first 2 minutes is Dr. Fite explaining the report card in a way that really makes a lot of sense. The next 2 minutes we're not going to watch because it's a call to action for the members of the college for legislation, and that would be inappropriate to be here. So when you see it go from female to male, we got to stop, even though their hair is about the same length. But anyway, we'll let's see if we can get this. Yes, it's Rick. It's Rick Robinson, the president of TSEP. Let's see if we can get this to work, because she explains it very well. That's not right. Give us a second to.
Texas got a grade of F in access to emergency care for multiple reasons. Among those reasons are that we have too many patients for the number of doctors we have. We have a very large uninsured population. A lot of them have to go to the
Let's see
emergency
what,
department.
and she's working on it to get the audio to work. One of the biggest areas that Texas was graded low on that I think kind of shocked all of us is disaster preparedness. And I see some heads nodding. It's like, but we thought we were doing a really good job in disaster preparedness. Again, it doesn't have to do with the job we are doing necessarily, with the funding that is available for the disaster preparedness. The same way, one of the reasons that we were got a bad grade, if you will, is the lack of a statewide EMS medical director. That is actually, we've talked about that in the past. We've discussed it quite a bit. We're going to put it back on our agenda for the EMS medical directors again. And again, bad grade due to funding opportunities, not due to the job that we are doing. Please tell me you can get that to work, Starla.
The report card does not grade emergency care in Texas. It grades the environment in which our patients live.
Should we come back to this? Yeah. Is that microphone on?
A grade of F in access to emergency care for multiple reasons. Among those reasons are that we have too many patients for the number of doctors
Why is it
we
not
have.
picking it up?
We have a very large uninsured population. A lot of them have to go to the emergency department for care. And in Texas, the Medicaid fees
Maybe we should take. Maybe we should come back to this rather than wait on the technical. Dr. Fight's explanation is way better than what I can do.
Texas also got an F grade for patient quality and safety. And this is primarily due to EMS issues. We don't get funding for quality improvement in EMS, and there's
restart and turn it
real quiet. I think we can hear it.
Medical director for EMS. Now, the report card does not grade emergency care in Texas. It grades the environment in which our patients live and in which we practice emergency medicine. Texas got a grade of F in access to emergency care for multiple reasons. Among those reasons are that we have too many patients for the number of doctors we have. We have a very large uninsured population. A lot of them have to go to the emergency department for care. And in Texas, the Medicaid fees are very low, so many primary care physicians cannot see those patients in their offices, and they have to come to the emergency department. Texas also got an F grade for patient quality and safety environment, and this is primarily due to EMS issues. We don't get funding for quality improvement in EMS, and there's no funding for a statewide medical director for EMS. Now, that may not actually be the best for Texas, with Texas being such a large state. However, the national organization deems a statewide medical director to be best for patient care. Texas also got an F in public health and injury prevention for multiple reasons, among which is our large number of traffic fatalities related to alcohol, also related to having no motorcycle helmet requirement, and to the large number of adult and childhood obese patients. Now, Texas did get an A in the medical liability environment, so that was good. And Texas got a C for disaster preparedness. The only reason we got a C was because we don't have much dedicated funding to disaster preparedness. But we actually do have a lot of preparedness for disasters in place in Texas.
Okay, so that's the.
In terms of
So that's the explanation, and it's very concise. I hope people could hear that. I apologize, but it's not a reflection on the care we provide. It's very easy to misinterpret that, but it's a discussion of the environment of care, and that's actually how it's worded: environment of care. And a lot of it, again, has to do with funding and funding opportunities within the state, and the number of providers versus the number of patients. So.
Any questions for Dr. Greenberg?
Compared to 2009, are we better or worse?
That's it. It's actually on your paper there. You can see the
So
comparison.
there's-
Yeah, other side, top right corner.
Okay.
It shows the previous grade and the current grade. So we actually went up. For example, disaster preparedness is the one thing I think everybody focused on for us. We actually went up but we're still below what I think everybody thinks we should be. Yeah, but everything else went down, except for the medical liability. And our medical liability went down too, and I can't remember the exact reason for that, because there's so many different factors. Yeah. Well, we already had the tort laws in 2009.
So why did the quality and patient safety go down so substantively?
Again, I think that has, if you read the brief in there, it'll talk about the fund, because there's no funding for quality, there's no incentives for patient quality. So it's not necessarily that the quality of care has gone down, but the incentives for quality of care, the environment for quality of care.
Is it also the state, we don't have a state medical director?
Yes, that's, if you look for that was one of the weaknesses for EMS, is the lack of a state medical director. Now, we've talked about that before, and a lot of people in the room would say that's a strength, is that we don't have a state medical director. So that's because when you think about a state medical director, you think immediately about state protocols. Everybody has the same protocols. Some lack local control, and in a delegated practice state, what do you do with a state medical director? The problem is, without a designated state medical director, there's an empty chair at the table of national meetings. Now, we have in the past designated the EMS medical director representative to GETAC to represent us.
I think that's an excellent idea.
Not on the agenda.
Well, you're learning the rules of this committee awful fast. But that's one of the reasons why EMS was low.
So if we did send someone to fill that chair, whether we had a medical director per se, because you're right, Texas is a large state, that would be helpful, correct?
Yeah, well, and we had in the past, we truly had designated the EMS medical director to this committee before.
Right, so it can be put on an agenda.
Yes.
Oh,
Actually, it's going to be on my agenda for medical directors next in May. We are going to discuss the pros and cons and come to the council.
Well, it just seems like that's, low-hanging fruit, so to speak,
as
far as,
It actually takes a legislative change, I believe, to have a state EMS medical director. And you can do it for free?
I wasn't talking I wasn't talking about that. I was talking about just filling this seat.
Yeah, to fill the seat, I think I don't know, Dr. Phillips was the previous representative. I don't know if he ever attended any of the national meetings or not. Right. And I don't know that we actually have funding to send Dr. Beeson. Congratulations. Welcome to the committee.
Any further discussion on this topic? Anything else? Okay. Then we'll move on to item 5, which is review the online medical director's course adapted by the National Highway Traffic Safety Administration, developed by the National Association of EMS Physicians and the American College of Emergency Physicians, meeting the education requirements of Title 22, Part 9, Chapter 197, Rule 197.3, Offline Medical Director.
Now, that was a mouthful. So, committee, this was reviewed by the Education and the Medical Committee yesterday or the day before. And it's not on the agenda for any kind of action today. It's more of an awareness, understanding that we can't approve a program. It has to go to the Texas Medical Board for their final approval. But it would help us as we move forward to be able to say that it was reviewed by the physicians, the education, and as well as GETAC in general. And this is a program that's an online program that a lot of the physicians who I spoke to yesterday were aware of. That it's been out there for a couple of years. We do have 4 physicians right now that are reviewing the course. We got access to them to go in and look at it to make sure there's nothing crazy in there. And it's an 8-chapter, and you have a handout in your pamphlet. There's an 8-section to this program, and then the number 8 part of it is that Texas gets to put in a whole chapter on Texas EMS and the rules and that process, which we'll develop in conjunction with the Medical Advisory Committee. So I just wanted to bring it to your attention. Our goal is to, unless there's a big outroar saying this is just the worst thing we've ever done, is to go forward and try to get funding to support the physicians to take this program over the next year. You have a year to complete it. It'll be free. If you don't take it at that time, then it's going to cost you about $300 to take this program. It goes in conjunction with what Jody said this morning with they're going to do a face-to-face program, but there's just a time where you just can't get people in a room. It takes about 3 to 4 hours. You can stop and start to take this. You get a certificate at the end of it. And anyone who's not a physician can take this course either. You don't get credits as a physician, but you can take this course, complete it, and at no cost to you too. So if a physician is using a nurse, a paramedic, an EMT, or whatever to assist them in the services, they can go online and take this course too. So we're going to move forward with this unless I hear a big uproar here today, try to get the funding to support this. Hopefully this will be in place by about September, and we will have to go to the Texas Medical Board to get final approval. And I'll answer any questions.
Any uproar from council?
Just point of clarification. This program that we're talking about was not developed by NMSP or ACEP. It was developed through a document which is guide for preparing medical directors. That document was developed by NMSP and ACEP. This is actually a private entity. There's going to be 4 of the medical directors who are actually going to go through and look at this course for content. But I just want to make sure that this actual program we're talking about online was not developed by ACEP or NMSP.
But it is adopted by NHTSA, the National Traffic Hospital or Highway Safety, and there has been input from the National Association of EMS Physicians and the American College of EMS Physicians. So, and many other states are using this current program at this time.
Okay.
Joe, if they get a certificate, is it a certificate of completion and is there CE?
I believe there is CEs for the doctors, but we didn't have that discussion about anybody else.
But doesn't CME also count for?
It does. So if they got it for the docs, it just trickles down. It'll automatically apply for EMS.
Yeah. And that it would be our plan that there are many doctors who have already taken this course in Texas that we would recognize that. Maybe they just have to do that one little Texas part. But that would eliminate, some people have to take it twice. Any questions for me? Thank you.
Thank you. Now we'll move to item 6 on the agenda is presentation of the Texas Medical Association's Hard Hats for Little Heads program that provides bike helmets to children, to be presented by Tammy, is it Wishard? TMA Outreach Coordinator.
She was here yesterday.
Going once. Going twice. Okay. At this point, we will take general public comment on anything other than the strategic planning that we're about ready to go back into. Does anybody have any other comments about any topic? And by the way, when the council starts talking about the strategic planning stuff, you're all welcome to stay, and we are taking public comment during that process. But we want to wrap up all the other business and then move to that. Go ahead.
Wanted to mention one thing. There is a, just for the good of the order of everybody, there is a new organization that's being formed to represent EMS in Texas. Its purpose is to be an all-inclusive organization. The proposed bylaws of that organization include set board seats based upon agency type to avoid any concerns that have happened in the back, or that's just a fire organization, or that's just a private ambulance organization. I think it's something that's long overdue for the state of Texas. There's a lot of big players involved across the state of Texas. The inaugural kickoff meeting for that is going to be called the Texas EMS Alliance. The inaugural kickoff will be the Thursday before the Eagles Conference in Dallas at the Eagles Hotel at 9 o'clock in the morning. I think there's actually a little continental breakfast being done at 8:30 just for a meet and greet time. And I think that's really the inaugural meeting of the organization. They'll be adopting their formal bylaws and appointing an interim board until they can hold elections later on this year. I think it's something that's long overdue in Texas, is a group of people coming together to try to speak with a unified voice and tackle the 80% of the issues that all agencies have in common, regardless of their agency makeup and structure, and to hopefully get our industry in Texas as best we can away from fighting with each other about the 20% of the stuff that we'll never agree on. If we can focus on that 80% of the stuff, I think we can move our industry forward with a unified voice. There's a group of medical directors that are also interested in becoming kind of an advisory group to that organization as well, so seems to have a lot of momentum. It's called the Texas EMS Alliance. There's a presence on the web at txemsa.com. And there's also presence on Facebook under Texas EMS Alliance that you're welcome to go like and get some information about the meeting. So I think that's very positive. I just wanted to mention that here for folks that haven't heard about it because it's difficult to communicate with everybody. The other piece was I got contacted by some folks that aren't here, and again, this goes to TTAF publicizing and putting all these meetings on the web. But when we have these issues that come up at last minute, or we're going to do some things and we put them in this room, that handicaps people who have become dependent or have become to rely upon the fact that we're broadcasting all the committee meetings. And we put committee meetings into a room that was overflowing, and we did business in here with 8, 10, 12 people in the chairs besides who was at the table. And that's not just the strategic planning session, that was the RAC stuff as well. So there was, there's folks outside of here that depend or have come to rely upon, if they can't make it, to get to attend the committees they're interested in via the web. And then we took that away from them with little or no notice in a bad weather time where some of them didn't have an option about going ahead and coming into town for the committees that they work with or are interested in. And then lastly, Chief, sitting here listening today, this is kind of tied to strategic plan. I can talk about it then, but I'll take your preference on that. It just has to do with you guys and maybe needing to institute another method of support for things that the committees are doing when there's time-sensitive things that come up without having to wait a quarter to take official action on.
If you wouldn't mind, if you could hold the comment
Okay.
until we get into strategic planning, because your comment's relative, and we just want to make sure we're all brains in the same mode.
Not a problem.
Okay, thank you. Any other public comment on any other item other than the GETAC strategic or the state EMS and trauma plan? Any other council comments other than those two items?
Mr. Chair, I was negligent. Education Committee has two new members. One is Mr. Jay Cloud, who's here today. Jay, raise your hand or stand up. I just want everyone to know who you are. And then also Dr. Taylor Radcliffe. I don't see him here today. He's not here, but those were our two members. I was negligent in recognizing them earlier.
Any other comments from council? Any other comments from stakeholders, general public? Seeing none, we'll move into items 1 and 3, which is about the GETAC strategic plan. We have John and Martha are back with us again today. Did you want me to just kind of summarize, or were you going to do that?
Mr. Chairman, whichever you would prefer.
Okay, well, I'll summarize, and where I fall short, please feel free to fill in.
Yes,
and
sir.
council as well. When we met yesterday, we worked on two items. One is our GETAC strategic plan, which Dudley referenced to, and that's how the council conducts the business among the stakeholders. And the second part was the state EMS and trauma plan. We've made some recommended changes in the GETAC strategic plan. I would say probably the main ones were taking stuff out of that plan and making them actual procedural rules, so they're not a goal anymore. They're actually part of how we conduct the business. And then the second component was the state EMS and trauma plan that was developed in 2002. We decided to bring that document back and make modifications to that. We know that the RAC assessments are going on. That's going to be a 2 to 3 year process. We don't want to wait that long. Let's look at what we've accomplished out of 2002, look at the ACS survey, modify that document, and then plan on 3 or 4 years going back in and making this a living document that we look at every 3 or 4 years. And I'll turn it over to you, John.
Thank you, Mr. Chairman. I think one of the things that we'll need to do also that I didn't think about yesterday, I think which will follow along with your your summary of yesterday's activities is just to go through one by one, just to make sure we're all on the same page of the changes that we talked about yesterday, and that way we can hold a formal vote to make sure that this gets entered into the record. So we didn't quite do that. I think the other thing that we have on store is we did go through the council strategic plan goals A through J yesterday. One of the things that we, when we recessed or when the meeting closed yesterday, the decision was made to allow you all to think overnight about, are there any new items that ought to go onto the council strategic plan? And I've got a couple of notes of some things that you may wish to consider based on the conversation. But I will ask just very quickly, does anybody have any additional comments on A through J from yesterday that they would like to put out for the record at this point in time? Or would you like for me to go and provide some comments on some potential new activities?
Nothing from council. I do believe we have one stakeholder, Dudley, wanted to make a comment on something that we talked about yesterday that was an item, A through J item. Okay. And if anybody else does after Dudley, we'll be happy to listen to you.
It's just occurred while I was listening to all the reports today. Yesterday we talked a lot about getting the action items on and the agendas and how to get those set and all the documents in and all that other stuff. But there was one, and the issue in particular that struck me was the cardiac committee's work, and they got a report in there of the money that was allocated this year to the Stroke and Cardiovascular Council to help get some things done. And the Stroke and Cardiovascular Council was very interested in using the discretionary money they have to get some funds to the RACs to help with. It's not a lot of money, but it's a little money to help them with their development of their stroke and cardiac systems. And the cardiac committee said, and the report was that was going to be going, and there would have to be a contract amendment. That would take a little bit of time. But the discussion came up about, well, there was a lot of things just because the stroke system is in legislation, and there's a lot of things there and a lot of effort there with RAC involvement already. The cardiac committee had a suggestion that, well, why don't we ask if we could get a deliverable, because we have this survey and we haven't gotten real good response to it. Is that we just ask, as a part of that, it's not hard, but we ask the RACs to make sure that we get that survey filled out. And when that came up, I was thinking, because to get GETAC to take action and approve that is, by the processes, is going to take till May with the open meetings requirements and all that other stuff and getting it posted. But I don't know. I know that is critically important when we're talking about policy and when we're talking about rules and regulations and things that we work on for an extended period of time. But I'm wondering if the council could think of, and with legal blessing on open meetings requirements, come up with a way when things come up like that really don't need approval more than everybody going, yeah, that sounds like a pretty good idea. And I'll go back to the example a lot of us used yesterday from our municipal or county government experience, is that we'll do a presentation to City Council. We're not ready for a formal vote. The ordinance isn't ready or any of that other stuff, but we'll do a presentation and say, this is the direction we want to go. And basically we're saying, is everybody okay with that? Because if you're not, we're not going to waste any more energy working on it. If you are, we'll come back when we have the ordinance. We'll come back when we have that. So it's almost, is there a consensus of, can we develop an intermediary level for not the big things, but things like that where they just need you guys to say, that sounds like a good idea, so that they hear that, so that when it comes down, if one voice, say stroke is louder than cardiovascular, and all they want is this one little thing, that you guys have said, that sounds like a good idea. You're not saying it's absolutely the right way to go. And I could see that. I heard that on a couple of other committee reports, where I think a lot of times we engage in that conversation and we walk away feeling that everybody says, okay, that's okay. But I don't know if there could be, for these times, and I call it time sensitive. I mean, it's probably not that time sensitive, but they're wanting to get that money out. I mean, we're halfway through the first year of the budget. And so just sitting back there thinking, I was just wanting to bring that idea up on some of those things that aren't crash, burn, die issues, long-term issues, where a committee has talked about a topic that's real time and would just like you guys to say, yeah, that sounds pretty good. Almost a consensus. Does that make sense? Am I making sense? What I'm asking about?
Yeah, but yeah.
Okay.
It does, but every time we think that something's non-controversial, it's not. So, and I can just see it where the council or a subset of the council makes a decision, and there's all kinds of uproar. Not that that would ever happen, but
It always has.
it always does. Yeah. As soon as we think something's a no-brainer, then it's a problem. Because all the city council meetings you keep talking about, you remember that one little old lady that keeps showing up? Every time you think something's a no-brainer, we have the same thing. So I understand your concern. I share your concern. I'm trying to expedite as much as I can. But I think when we start talking about shortcuts, we have a problem.
Well, and I don't think I was really saying we should take a shortcut as much as if there are those areas where a committee's looking for, yeah, that sounds okay, where they could, I don't know. My concern, we're going to come back in May. Stroke and Cardiovascular Council will have already made up their decisions on what they're going to do. The contracts will be drafted or in the process of being drafted, and we're going to be a day late and a dollar short from one of our work groups being able to have some input in that. I mean, I know she heard it, and I know her staff has heard that. That's just my concern, is on some of these things, we're not talking about, having to put unit number or agency license numbers on the side of ambulances here. We're not talking about accreditation. We're not talking about the things that cause controversy. This is a group saying, we just want to make sure that we can get some of the work done that we've been charged to get done, and this seems like a really easy, low-hanging fruit to have cardiac, I don't even want to use that one. I'm trying to think of another one that the EMS committee has done or something. I don't know. Y'all may be right, but I just wanted to bring that up. I'm concerned that on some of the I don't want to say non-issues, on some of the non-critical issues, on some of the not changing rules and regulations that are going to affect every agency in the state of Texas. We're not changing a rule and those type of things, that we're going to get so bogged down in having to wait till the next time and bring it back that it's almost going to become ineffective. That's my concern on some of those issues, and things are going to go around this consensus stakeholder body. That's my concern.
Thank you. I concur with you as well, Dudley. We only meet 4 times a year, and there's sometimes you can't wait for the next meeting. And so I think when we move through these goals, that maybe there's something there's enough brain power in the room. We can come up with a way to stay completely legal and ethical, and still be able to give a nod or some general feeling. And I don't know how to get that without a lot of legal counsel on that. But we'll let you go ahead. Anybody else have any comments? And we will allow public comment later as well. So I'm sorry. Go ahead, John.
Thank you, Mr. Chairman, members of the council. I think one of the things that we'll talk about may be an opportunity to address kind of this comment that Mr. Waite had provided. I've put up very quickly on the screen for members of the council and members of the audience, just as a reminder of the goals that we talked about yesterday. And I think I'm just going to go through them very quickly and just summarize what we discussed, just as a reminder. And I think that may help remind you of some things that you think you may would like to consider. Goal letter A was to develop a framework to apply the council vision and mission statement to all decisions made by the council. I think you all have been successful in that. I think there was the comment that you would like to move that to policy and procedure, and to also make this part of the committee agenda and opening remarks as well. So this is not going to necessarily, the goal will be kept, but it'll also be moved to policy and procedure. But I think I understood you still wanted just to have this in here just as a reminder, if I'm not mistaken, or at least that's what I had in my last note. Or does this goal come out as completed but now move to policy and procedure?
Anyone on council have any comment on that?
I have in my notes that we would put it in policy and procedure.
Yeah. I was under the impression this was coming out of the plan and into procedure.
I think that's right. And I don't think I made that final note. We do have it in our other notes. So that will come out, but it'll be in policy and procedure. Goal B, increase collaboration between the council and stakeholders involved in EMS trauma. There's still understanding that there's still a little bit of work to be done on that. One of the things that Dr. Greenberg and Mr. Harbert noted is that they'll continue to work to develop standard meeting times for committee meetings, and then also work to develop a liaison for each of the committee meetings. So my understanding is this one will stay in, but the activities will be changed slightly to reflect some work still to occur. Goal C, to undertake a review of all committees to define the optimal number of committees based on need, structure, charges, reporting relationships, membership, and decision-making progress. Based on these individual items, I'll run through them. This is what I believe we had talked about, is that defining the optimal number of committees. This is something that would continue to be reviewed on a biannual basis. That the structure of appointing a council member to serve or be a part of each committee is going to now be addressed by Goal B, the liaison. Charges for the committees, the suggested topics, and how these are reviewed by the council, that this is happening by default now, but this would go into a policy and procedure to kind of codify this. The membership of the committees, there was some discussion about this. I believe that this is moving along, but this should also be put into policy to codify how you would like to handle committee membership and to develop an SOP for this. And then for the decision-making process related to decisions that are made in committees, that an SOP should be developed to codify this, but my understanding is that the process is working, but there's just not a policy or procedure in place. So most of the things under Goal C is my impression, will move to a policy or procedure. Goal D, as in David, is to develop a process to improve operation of GETAC committees. I believe the point that we have here is related to an annual council meeting with committee chairs, possibly as a part of one of the GETAC meetings or EMS conference. I believe there was still some work need to be done on this, but I understood that holding the annual council meeting with committee chairs may be more appropriate in a GETAC meeting rather than in the November conference, because there's so many things that are ongoing at that point in time, and that it would be nice to have a mechanism to kind of clarify administrative and clerical processes related to the operation of the GETAC committees. I believe we also had heard at one point in time a comment about minutes for the GETAC committees, and as I recall, the administrative rules state that minutes will be taken. I don't know if that's something you may want to consider adding to Goal D as a new item or clarification of an item. And I believe, Dr. Tyrock, I believe that was your comment from yesterday about the minutes from the committee meetings.
Yeah, but I thought Jane said that was already policy.
It is.
Yeah, we're just not enforced. We're not doing it.
I think it's just a lack of awareness that it's there.
But I think it's very helpful to have the minutes so we can review them and stuff.
So we won't necessarily add anything on that, but I think review and try to figure out how to make that known that that is current policy and that it should occur. Goal E, which we spent most of our time talking about yesterday, is updating the existing EMS trauma system strategic plan at least every 5 years beginning in 2012. The discussion that we had yesterday was receiving member feedback and ideas related to who should be involved, how they should be involved, how the ACS, the different components of the ACS that have occurred and are ongoing would impact this. I believe we left that with that the Leidecker Group will work with Jane to develop a 3 or 4 pager of a draft plan for how all this would be accomplished over the next 12 months to 18 months and provide this back to you at a subsequent meeting, but prior to the May meeting, I believe. And Chief Riley, I'll stop here and ask if council meeting members have questions at this point.
The only comment I had was in looking at the existing EMS trauma strategic plan. I think there's 2 or 3 paragraphs in there that describe the process they went through. Surveys and meetings and things like that. So that might be a place to look as to when we're working on how we're going to do it. Any other comments from council?
Yes, sir. I think we also discussed potentially using our stakeholders that participated in the initial plan, that some of they're still in the system, to actually adopt the plan or develop the plan.
As well as the emphasis on a living document that every 2 years we come back and look at it. I mean, it's going to take probably 2 years to finish this, but.
And my very quick summary did not do justice to the full discussion that we had yesterday, but the document that we provide back to the council will reflect the discussion that we had yesterday. So, but thank you for reminding us of your comments related to those areas. Goal F was to improve the process of communication between DSHS and GETAC, and I believe that the majority of time was spent on two issues. As one is making sure that documents were available for a set number of days prior to the meeting. And Jane, I'll have to ask you because I want to make sure that I don't misspeak, but the documents would be made available to you the Monday close of business prior to the GETAC week.
Yes.
I know we had lots of
45 days, right?
I know we had a lot of discussion on that yesterday, so I wanted to make sure to try to.
I think it turns out, and actually, yeah, we'll go ahead and open it back up because I have one of those 3:30 in the morning things. Because we don't always meet on a Friday, we probably need to state a specific number of business days. Close of business 9 days before the council meeting or something would be better.
Okay.
We can do that.
So what we're
You
here.
had to think about that.
9 business days before the council meeting, the documents would need to be provided. Yes, sir.
November is particularly busy. That's the only exception is November. And it's particularly busy because of the conference. So I think we need to look at Jane again and have her tell us when it needs to be in. And to me, a deadline's to me, a deadline's a deadline. However many days out is fine. But, yeah, just tell us when. But, yeah, you're right.
So there may be exceptions to your 9-day policy that could be communicated.
No. It's just
No.
It's just not the Monday thing.
Okay.
It's just the days.
Okay.
What we were talking about yesterday was actually 9, let's see, that would be, it's actually by the close of business 9 days prior to the council meeting, which would be on the 10th day. Business day. Okay, so if the council meeting's on the Friday, so it is the Monday week before close
Jane,
of business.
do you think you could just publish those days when we have, we have GETAC during this date?
Absolutely.
All documents are due by this date, so we're looking at it side by side.
Absolutely.
And then done. Okay, good.
But I think council's intent in to support DSHS is to have about 9 business days, but we'll let them post the actual.
Yeah.
And the other item that we discussed on this was making a concerted effort to have more documents available electronically ahead of time to council members. So these two kind of go hand in hand. Goal G was develop, refine the system for orientation for council members. We had 2 comments related to this. In the past, I understand that the governor's office conducted an orientation. Due to the swift work of Dr. Greenberg here, we heard that is no longer the case, and that the governor's office has suggested that this be a department responsibility. There are some ongoing items related to training for council and committee members. So I think my sense from this is that there's still some work to be done on this, particularly in light of Dr. Greenberg's feedback from the governor's office. Goal H is to conduct a GETAC strategic plan review at least every 2 years, which we're doing. My understanding is that this would become a procedural rule, but that you would also leave it as a goal because you felt like it was important to show this. Is that?
Yes. Any comments from council on that one? Nope.
Goal I, partner with organizations to support GETAC activities as necessary. I believe, Ms. Schultz, my understanding is that you felt like there were still some things that could be done in this area and that you would like to keep this as a particular goal, although some collaboration and stakeholder activities have occurred. And Goal J, organize the regularly scheduled quarterly GETAC business to 2-day meetings. I understand that a lot of work went into this last year, and at this point in time, I believe the suggestion was to retire this goal.
That's putting it mildly.
It's a spirited process sometimes, I believe. So at this point in time, I would ask the chair and the council members, are there other things that you think need to come on the table, so to speak, for additional goals or things that you would like to focus on the next 2 years that has not already been discussed or is not currently a part of the council's strategic plan?
I've been seeing some hands pop up and down as we've discussed these goals, so if the council members didn't have any other goals, it'd be good for stakeholder input at this time. Or did I see somebody? Not seeing any arguments. So any of our stakeholders or anyone in the room that would like to come comment, come to the microphone.
Mr. Chair, committee, council members, one of the things I think is very important for us is data. So we come to these meetings and we make decisions, but we really don't know, are these decisions causing good things or bad things? So I assume that most of everything that we're doing is moving us forward. Based on the outcomes in the trauma centers, we see good things. Based on EMS, we see good things. But, you know, the registry is working very hard to improve itself. So one of the things I think we should have is some type of data that we look at to see on a quarterly basis or an annual basis, where are we headed, you know, what have we accomplished, what have we not accomplished, how do we compare to other states, you know, and I don't know if that could be wrapped into one of the other goals that you have or whether it should be a standalone goal, but we should use data to drive our system.
Would you consider that to be, what we've talked about so far is the council GETAC stakeholder process. Are you suggesting that we have some sort of reports on our progress there, or is this more towards the state EMS trauma plan?
Well, either you have data that the state gives to you before the meeting, or you hold us as committee members, committee chairs, accountable to bring you data. Could work either way. It's kind of like your committees at the hospital. You know, you have some type of report that you want, and sometimes they have to bring you the report to show you so you can make decisions on it. So I just think that we as a state really need to begin to look at data. We need to look at outcomes. We need to look at comparison data. I know that as we move forward as trauma centers, the American College of Surgeons is going to hold us accountable to compare our outcomes to others, to say what are we doing right, and to sit down and reevaluate things that perhaps we're below the mark. So I would think that I think Texas is a leader in the EMS trauma system, and I would like to see us embrace that and use that to begin to move forward. An example is Jody has started this medical director's course years ago. So I think one of the things that we might look at from data is, well, how many of the medical directors that are out there today have had some type of training? If we introduce this course, how many people have had it in a year from now? That's opportunities to look at moving forward and improvements. And it doesn't mean it's all clinically related. It means that we're beginning to look at data to help drive our system and where our opportunities and where our tasks really need to focus.
Thank you. I'll throw this open to council for discussion. I think that might go in the goal that had to do with committee work or one of the others. But anyway, I'll let council.
I think it's a great idea, Jory. And I think it should come from the committees. Perhaps every quarter when you come and give your report, there's something that's on your agenda to give us. And the committees will decide what is their time frame to report, what are they reporting. The council may very well ask for the next time we want specific information, but I think it should be driven from the committees. It's a great idea.
Data sharing, what Dory's talking about is a big part of the strategic plan. And if you read the document that's over a decade old, it's still a problem that's not fixed in this state. So if we want data to drive what we do, then we need the data. So that's going to be a huge portion of the strategic plan.
See, I guess my request is when the data comes to you, you give us some direction. You know, I'll tell you my pet peeve. Texas continues to be the #1, sometimes #2 state with alcohol-related deaths. We don't have an action plan. After 20 years of doing GETAC, EHAC, TTAC, we don't have a plan how to address that today. So are we just saying that's okay? Are we ignoring it? What is the plan? We don't have a plan. That's the kind of things I think we need to bring stuff to you and you give us direction. We are going to do this or we're not going to do it.
So we would be talking about, council, we might be adding something to Goal D, which is the process to improve the operation of the committees and Goal E, which is the actual state plan itself. I think it would fit in two different places well.
I think
also one of the important things is actually using the committees and the council to derive the appropriate metrics that we want to look at from that data.
I think, Jory, if I'm hearing you right, I'm trying to associate this to something else, more of a State of the Union, almost. What have we done since we twice a year? What have we accomplished? What have we done? And I think that part of that has to come from the committee. And I know Judge and I've talked about this quite often, is that sometimes we need to drive the committee to do certain things to get that data back, because we can all work on stuff, but it may not be data driven, and it may not be something that's coming back to give us the information. So we as a council might have to ask the committees, we need you to work on this, get back with us to get that data, to put together a State of the Union twice a year, to go through that process, which we all hate, and it's called evaluation. What have we done with it since we last touched it? Is that kind of what you're talking about? Okay.
I mean, when you sit in the back, when you have the GETAC meetings, there's so many good things that are discussed. You know, and I don't know about you, but I'm very proud to be part of this process because I do think we're making a difference. But at the same time, you'll hear some things that come back to the committee over and over and over, and there's no improvement. There's no opportunity to address it, or it sounds like we're just going to say, okay, we're going to take that. So if that's the truth, then we need to own that, or we need to say, no, we're not going to do that. You know, and the other thing I just want to bring up is that the RACs are probably one of the most critical piece of this entire process. And so their voice, their involvement in GETAC needs to be really recognized and create an opportunity for the RAC chairs to have a specific committee to come to you with information.
I think what you're talking about, though, it really is a new goal. When we look at these goals, what you're talking about doesn't fit in here. Part of the reason I think we haven't had the goal is because we haven't had a database, or we certainly haven't had a database we trust. Right. We're still not sure if we have a database we trust.
I'll be the first one to say there's been lots of questions and consternation with the registry. But I can tell you that we are investing time, effort, and resources, not just in Tammy's group, but in each one of the committees. There's a person assigned to work with that. I mean, Dr. Beeson has been on that. My trauma registrar, multiple trauma registrars have been involved in that. It is getting better. We're going to get there. That is one of my goals before I retire, is we're going to have good data in the state of Texas.
And so I think if we make that one of the goals of this council is to review reports from the database, from the, I can't use the exact, what are we calling it now? The trauma registry. Texas State
EMS trauma registry.
That one of our goals should be to review that on a X amount basis. It could be even quarterly, to review reports from that, and that should naturally drive us to action, I would hope.
Looking at the trauma system plan from 12 years ago, there's several objectives, and they call them strategies, and a lot of them were for 2004. The question I asked yesterday, well, did we meet them? I know we probably didn't, just because I know the answers, but did we meet them? Did we not meet them? We need to make sure that we're meeting these objectives and have time frames as to when will they be met, and if we didn't meet them, why not? What's the next strategy?
Great.
I want to kind of add one thing in there. I know that we sometimes get micro-focused on the registry, and registry is important to drive our care, but there's also things that I picked up on that she was talking about. For instance, how many physicians have had some sort of an EMS medical director's course. Obviously, our goal is to have 100% compliance with the new legislation. However, or excuse me, not legislation, it was a decision of the board. Excuse me. But the other things that we've never really addressed and we let fly around anecdotally are important things. So there are other data elements that we need to probably collect and have a surveillance program on that would never be derived from the registry. For instance, how many paramedics are still practicing regularly in the state of Texas? How many providers? What counties have a shortage of providers? These are all things that should be driven within the trauma plan, that there's never really been a mechanism or a surveillance piece to look at those things. So we see a lot of attrition out of EMS. We can talk about it anecdotally, but we don't have a whole lot of hard numbers. So I think that it would be worthwhile to, as Dr. Greenberg said, to create another strategy within our plan that starts to address things not only just patient care driven, but also the ancillary things.
I think I'm hearing a lot of different goals popping up, and I don't want to lose any of them by continue. Can we take them one at a time, or I'm kind of afraid they'll kind of muddle together.
And if I may make a suggestion
Sure.
to the council, again, just because we've heard several different terms, strategies, goals, objectives, the council may wish to consider that the goal, which would be, and I'd have to put my glasses on because I can't see, sorry, the goals which are broad, long-term aims that define accomplishments of the mission, maybe the goal is a little bit broader related to data, that the council will use data on a regular basis to help drive a decision-making process, whereas some of the items that you talked about and Ms. Klein mentioned, the EMS trauma registry could be an action item within that goal, identifying other data related to paramedics or other issues could be part of that. The idea of metrics and what you would like to do with that data could be action items under that. So I would put that forward for your consideration as a broader goal related to data and data review.
Okay, so that would become goal K, and also it would be part of the state plan, or whatever the next. I don't know if it's J or K or whatever's next, but
with the retirements, there may be some shuffling of the goals.
Yeah, that's true.
And it might be in goal D when we look at committees, because that's where the information will come from.
Right. So would you give that? You just gave the. Let me cheat. The goal, which was broad. I thought you captured it well, but I didn't write it while you were.
May I ask Martha if she captured in some semblance of what I put forward?
To use data on a regular basis to drive decision making.
It's too vague. I think that's too vague. I mean, we do that, but I think that's too vague.
Would you offer an amendment or a suggestion to that wording?
I would suggest we get reports from the Texas EMS Trauma Registry on a quarterly basis for review and action.
Would you, to be reflective of the comment of Mr. Matthews, that some data may not be in the EMS Trauma Registry, so EMS Trauma Registry and other sources on a regular basis?
I would actually put those as two separate goals.
Okay.
Don't we need to have a list of the data points that we want and the various topics, because it could well change the committee structure if we ask for pieces of data that the committee can't provide.
Probably should also know, what can the committees provide us already?
Could I offer you a suggestion? If you use terms like defined measures and evaluation tools, and then take the word data out of it, because sometimes it's not going to be always data that you're looking at. But if you define the measures or the outcomes that you're trying to accomplish, and then go from there. So define the outcome measures.
So perhaps then for a goal, rather than say define, maybe the goal would be the GETAC Council on a regular basis using outcome measures or having outcome measures reported, or using outcome measures to make decisions. And I'm just kind of thinking off the top of my head and trying to be reflective of your comment, Dr. Greenberg, that you do this on a regular basis. I think, Ms. Picard, some of the pieces that you just mentioned, I would suggest that those would probably fall a little bit lower, either as an objective or a strategy or a tactic, but I think you're correct in the sense that you need to do some of that defining and so forth in order to make it a goal that could work. So I'm just trying to keep us at the appropriate level for when we talk about a goal at this point in time. It's the broad thing that you want to do with outcome measures or data.
I would suggest that you also keep it broad to the emergency healthcare system, because you have committees on cardiac and stroke, disaster preparedness, and so perhaps a strategy might be the development of a dashboard.
We're looking at goals.
But I'm hoping it will explain it. Perhaps a dashboard that enables you to identify the outcomes that you're looking for, and then the individual committees would be responsible for bringing you the exact data that reflects that dashboard. So,
thank you.
So based on Ms. Hegelson's comment, could a goal would be the use of data? I guess I'm trying to be reflective of Dr. Greenberg's comment earlier that the council already does this. But is it the use of data to make decisions? Is it or is it the use of specific pieces of data that you're trying to quantify in that goal, like EMS and trauma data or other sources of data?
One possible way that we kind of use in our taxonomy is to track and trend emergency healthcare outcomes or something along that line.
That's good. Issues and outcomes will encompass everything.
Yeah.
I think we're going to have to look at the committees. For instance, the number of runs providers made last month by private providers is something the Education Committee would have no purview, no thought from. I think we're going to have to look at what each committee does and figure out what data they can provide us, what we need from each of them, and that's going to be a kind of a long-term goal because, again, if we just start getting data, goal, and information, it's going to be overwhelming, and we all know what happens. When data gets overwhelming, we just stop doing it because everybody just gets tired of it. So I think we're going to have to figure out what the committees can do, what they can provide, and then what we need from them. Otherwise, this is just going to be large and impossible to tackle.
Right. Could you do right now today, Jody? Could you do an education report on, for example, training gaps across Texas, or number of paramedics that didn't get trained last year because of whatever, things like that, without doing some pretty serious research?
No.
Yeah.
Not
exactly.
accurate, no.
Exactly.
What I would recommend we do is we try to stay at the goal level and get those established and locked in, and then we'll come back and worry about what we're going to put on the committees and those kinds of things.
Mr. Chairman, I would agree based in terms of terminology. I think, Mr. Harbert, kind of the things that you had just brought up would be more specific objectives or strategies of how you would meet that goal, because you could say, well, what can the committee do? Well, if committee can do X, Y, and Z, then that would help meet that tracking and trending. But if they can't do X, Y, or Z, then you could determine, do you want them to, how would they go about doing it, et cetera, et cetera. So I would agree with the chief on that comment.
Isn't the goal really we need data to drive the system? And that's really what we're trying to talk about here.
So is the use of data to drive system change or system activities?
And I think we need to use data or the defined measures, the outcomes, to drive the committee efforts. And if that should be broad enough that we could then take those each to the committees and define what we can and can't do, and work on the process from there. But I think it's important, I agree with Jory, rather than just using the word data, I think we need to look at some of those are going to be defined measures or outcome studies, and I think that'll be as important as some of the data that we're going to gather.
One of the things that I feel like that, and I just told Vance I'm going to mention this one more time,